Welcome, everybody. So we're going to get started tonight. We're just going to jump right into it. First of all, let's see who do we have here, because there's some faces I've never seen before. So, Kayla, you're new to the family. How are you doing?
I'm doing good. How are you?
I'm well. So do me a favor, if you don't mind. Here, let's pop you in the box for a moment and tell everybody where you're from, what's your situation, where are you right now? Like, where do you work? What do you do right now?
Well, I'm from Montana,
Okay.
and I'm working to pass my national registry for my EMT, and currently I'm running with the ambulance crew here in this my small town.
Okay.
Uh, uh, I don't know. I can't remember what else you asked for me to
Okay.
say.
And so yeah, so your name.
Oh, Kayla.
Okay. All right. So we've got Kayla from Montana. Okay. So welcome, Kayla. All right. So who else do we have? Garrett, are you able to turn on your camera, Garrett? Garrett, are you able to turn
Y-
on your?
Uh, yes, sir. I'm trying to help with my daughter real quick. I'll
Okay.
cut it on in about 10 minutes if
Hey,
that's
not
okay.
a problem. Not a problem. Let's go to Billy. So Billy, we finally get to meet each other. How you doing, my man? All right. You're muted.
There we go. Good. How are you?
I'm well, sir. How you doing? So tell everybody your name, where you from, and what are you doing right now?
My name is Billy. I work in Myrtle Beach, South Carolina, and
Okay.
I'm currently trying to pass my national registry paramedic.
Okay, good. All right. So we got EMTs, we got paramedics in the house. All right. So good. And I did see your question that you submitted, and I'm going to, I've got that queued up to answer that for you. So, all right. So
Sweet.
good. And if I don't get to it, just let me know. We'll try to make sure I'll try to get through as many questions as I can in the time that we have. We'll probably go for about, at least an hour and a half. If we need to go a little longer, we can, but at some point we'll just have to stop. Okay. Um, who else do we have? All right, Aisha, good to see you. How you doing? You want to introduce yourself? Let's see if we can get Aisha in. All right, Aisha, let's bring you in. How you doing?
I'm good. I'm sorry, my computer was muted. I'm
Okay, no
good. My
problem.
name is Yes, my name is Aisha, and I am a EMT trying to pass my paramedic test, and I am in the Memphis, Tennessee area.
Okay, all right. So far, Montana, South Carolina, Memphis. All right, so we're taking over the country. We got people everywhere. Now, welcome everybody. We're just going to go ahead and get started. Does anybody have any pressing questions? Tonight is not necessarily for me to go over any specific content. However, some of you already submitted questions, and I am going to try to get through as many of those as we can as time allows. One of them we probably won't get to just because it requires like its own session, and that's the lab values question. But I will kind of tell you some things to know and how to simplify it. So, any questions before we get started? Does anybody? So, here's what I want you to do. If you will go to at the bottom of your Zoom screen, there's a reactions button. If you don't mind, go ahead and just hit the reactions button, and there's a button that says raise hand. If you have a specific question, just go ahead and raise your hand, and I'll just kind of call on them in the order that they pop up on my screen. Does anybody have a pressing question right away? Because that's what this is all about tonight, is me asking or answering your questions that you have that are pressing. If you're confused about anything, that's what this is all about. So does anybody have any questions? If you will, go ahead and use the hand raise feature, and then I'll just start calling on those. Otherwise, I'll just go to the questions that were submitted. Hey, Eric, how you doing? All right, so maybe we can get Eric to turn on his camera. All right, so any questions? Let's see if I can, or any questions popping up? Hang on just a minute. Let me move my screen around. And hey, somebody just test it out to make sure that I'm seeing it on my end. So what I'm trying to, if somebody will hit the bottom, the reactions button, and just somebody just raise your hand just to make sure I know it's working. Okay, cool. Okay, cool. All right. All right. So if you will just lower your hand unless you have a question. If you do have a question, I'll go ahead and call on you. Does anybody have a question right this second? All right. So Eric has or no. All right. So it looks like Eric changed his mind. All right. So no questions right away. Let me just go ahead and go into the questions that were already submitted. And then if you have questions, there again, just raise your hand. No problem. So one of the first questions, let's get you to the iPad. So one of the first questions that got submitted was, Coach, what is the difference between angina versus a heart attack? So let's go ahead and tackle that one. So angina versus an MI. Now, when it comes to blood flow, and first of all, let me jump ahead for a second. One of the things is this is really important to know. So if you're already in the 14 days program, you're in the cohorts, you've probably seen this already, but this applies to everything we do in medicine. So kind of the starting point for a lot of things is ischemia. So that means the lack of blood flow. And then if you don't have ischemia, eventually there's not going to be enough oxygen flowing in the blood either. So that's going to lead to hypoxia. The next thing in the cascade of events is respiratory distress. So shortness of breath. Notice how I have everything color-coded. So ischemia, what's in red, these are primarily perfusion problems. Remember, everything comes down to oxygenation, ventilation, or perfusion. What's in red, these are primarily perfusion problems. Okay? Hypoxia and respiratory distress are primarily oxygenation problems where the issue is getting oxygen into the body. And then after respiratory distress, if we don't correct it, that's going to lead to respiratory failure. And then respiratory failure that we don't correct, that's going to lead to respiratory arrest where they quit breathing. And if we don't fix that in time, that's going to ultimately lead to cardiac arrest. So the end point for everything is cardiac arrest. Okay? Now that we know that, let's talk about another really important concept. And this is like the continuation or continuum of how every chronic disease kind of manifests. So we start off with like a lack of blood flow to an area. Well, because now we don't have blood flow to the area, the cells are not getting all the food it needs. So it's one of the first signs of cellular injury is going to be some kind of inflammation. So every chronic disease, think of anything with the word itis on it, with the suffix itis, pancreatitis, carditis, endocarditis, myarhabdolysis, or lysis. In any of this stuff, there's some kind of inflammatory component. The next thing that happens is the cell gets injured. Now, hopefully we can do something about it before it continues to progress, because if not, what's going to happen is not only is the cell going to get injured, eventually there's going to be so much tissue damage that it infarcts. Okay, so now things are starting to die. Cells are starting to die off. But eventually, things are just permanently die, and that's where we have necrosis. Now, so let's tie all that into this concept of angina versus MI. What is the difference? They both are like the same situation, it's just one is worse. So angina is kind of the earlier stage where you have a temporary interruption in blood flow. So blood is not flowing well through a coronary blood vessel. But if you can restore the perfusion, if you can restore the blood flow, the symptoms go away. So angina is where we have an ischemia problem, a lack of blood flow, and temporarily it's going to cause things like chest pain, discomfort, nausea, things like that. But once they sit down and rest, for instance, now they don't have as much demand on their heart and everything is fine. Okay? So now when it comes to angina, we classify it as one of two different flavors. We have what's called stable angina, and then we have unstable. What's the difference? Okay, so let me zoom in here. All right, notice this blood vessel. So we've got two blood vessels here. In stable angina, this first picture, this is stable angina. It's where you have some plaque that starts forming. Now, how does this plaque form? The number one cause is going to be cholesterol. Now, cholesterol, everybody talks about cholesterol being bad. You have to have cholesterol to live. Every hormone in the whole human body is originally made from cholesterol. If you had zero cholesterol, you would die because you wouldn't be able to make hormones, for instance, epinephrine, norepinephrine, insulin, glucagon. All of those are hormones that you need. Thyroid stimulating hormone, adrenocorticotropic hormone, thyroid releasing hormone, estrogen, progesterone, testosterone, all of those hormones that we need to live, the precursor, the starting point for everything is cholesterol. However, when you have too much cholesterol, or especially too much of the wrong kind of cholesterol, so LDLs, low density lipoproteins, it starts forming this plaque. Now, what happens is when this plaque forms in the blood vessel, initially, so make sure you're paying close attention because Billy, you're going to repeat this back to me in just a moment. So this plaque starts to form, and then it hooks up to the wall of the endothelium, the wall of the blood vessel. But as long as that plaque stays in place, it's nice and stable. Okay? That is what's called stable angina. So you have plaque that forms from like cholesterol, especially the wrong kind of cholesterol, LDL. You have too much of it. It forms a plaque. That plaque stays in place, but it kind of, because it's there, see, like if it, let's do it this way. Let's say there was no plaque there. Now, the blood just flows nice and smoothly. But once you have this plaque there, now there's something kind of interrupting the flow. So this first type of flow, this is called laminar flow. That's nice and smooth, laminar. The next type of flow is what's called turbulent flow. It's where like something's in the way. Kind of think of like water in a stream and there's a pebble or a boulder there. It has to kind of go around it. That's the same thing that's happening inside the blood vessel. It's not flowing as easily, but most of the vessel is still open so blood can flow. That's why the problem stops like when they sit down or that kind of thing, or they take a nitro and then the pain goes away in 3 or 5 minutes. That's stable angina. What is unstable angina? Once this plaque ruptures and then moves, the plaque is now unstable. So we now call that unstable angina. Okay, what's the difference? Stable angina is where you have a plaque, it stays in place, but blood is still flowing. Unstable angina is where that plaque ruptures, and now it's really getting in the way and blocking the blood flow. Is everybody with me on that? Give me a thumbs up reaction if you're with me. Okay, all right, cool. So that's stable versus unstable angina. So there again, angina is where you have a temporary interruption in blood flow due to ischemia. Now, what is an infarction? An infarction, an MI, a myocardial infarction, it's just where things have gotten worse. So now we have more damage to where there's been blood flow that's been interrupted so long, or so much blood flow has been interrupted that now we went from ischemia to inflammation to injury, and now we're at the point of infarction. Okay? Now, when it comes to this, we have like, okay, so this would be like a blood vessel for ischemia. There's a little plaque there that's blocking the blood flow, but most of the vessel is getting nice blood flow. Okay? On the other hand, let's say in this situation, in fact, let me change the color for a second. Okay, so where I am is right here. In this situation, this is where about 70% of the blood vessel is blocked. In this case, this is the point at which you start having real symptoms. So most of the symptoms happen. So as long as most of the blood vessel is not blocked, they have no symptoms at all. Once you hit the 70% mark, that's when your patient starts having chest pain, or starts having jaw pain, or numbness, or pain in their shoulder, pain in their arm, things like that. The 70% mark is where most of this starts happening. This is where a non-STEMI starts. Okay, so in an NSTEMI, this is where you're going to have ST segment depression instead of ST segment elevation. So this is kind of what it would look like. Okay, so we have, this would be this little area here, right here. This would be the ST depression. Now, what should normal look like? Okay, notice that these two don't look the same. This first one, this is a normal EKG. This second one is ST depression. That happens at once about 70% of the blood vessel is blocked due to an unstable plaque. On the other hand, let's go ahead and wipe out even more of the blood vessel. Let's make this plaque even bigger to where we have almost no blood flow. So once we hit the 90, or about 95, once we hit about 90 to 95% blockage, this is actually what happens in a STEMI. So now let me actually show you what this looks like. In a non-STEMI, all right, give me a second. Okay, if I were to take the heart and if I were to just cut it in half, like do a cross section of it, and I'm looking down into the heart, these are the 3 layers that I'm going to see. Okay, the outermost layer, type that in the chat. What is the outermost layer of the heart called? So we've got these 3 layers. What are those 3 layers called? What's the outermost layer called? Type it in the chat. Paramedics, you got to know this. Okay, good. Okay, nice. So that outermost layer is the epicardium. What's the middle layer called? The middle layer is very thick. It's the thick muscle part of the heart. That's going to be the myocardium. And what's the innermost layer where the blood is flowing? Okay, that's going to be the endocardium. All right, so let me show you here, let me just copy this for a second. So in a non-STEMI where you have ST depression, let me show you what's happening. Blood is flowing to the the outermost layer is getting affected. Oh, I'm sorry. No. Let me say that over. Let me just draw it. This part gets blood. The next part gets blood. But what's happening is the innermost layer, because it's so far away, because the blood vessel is out here. And the innermost layer, because it's so far away from the blood vessel initially, it doesn't get blood flow. So in this case, it's only the innermost layer of the heart that's dying off, and we call that a subendocardial infarct. This is what happens in a non-STEMI where you have ST depression. Let's go back over that. Once there's so much blood flow due to an unstable plaque, once we have at least 70% blockage, that's when symptoms start. In a non-STEMI with ST depression, what's happening is the outer 2 layers are getting blood flow, but the innermost layer is not getting blood flow. That's where the death is occurring, that part of the heart or the heart muscle. We call that a subendocardial infarction. On the other hand, let's talk about when somebody's having a STEMI. So what does it look like? On the EKG, okay, that is a STEMI. This is where we have at least 90. Actually, I want to make this 90 and not 95. This is where we have at least 90% blockage. And in this case, the entire thickness of the heart, all 3 layers die. So because it's all 3 layers, the word for layer is mural, and the word for across is trans. We call this a transmural infarct. It means across all the layers. A transmural infarct. Okay? That is what a STEMI actually is. Now, most people just know the part of, we have ST segment elevation. Now, by the way, why is this segment elevated instead of on the line? Why is that segment elevated? Can somebody tell me that? Who wants to teach that back to me? All right, paramedics, give me a paramedic to answer this one. Why does the line go up? Why do we have elevation? I don't want you to just know that we have it. I need you to understand why we have it. Somebody tell me why.
Is it ventricular repolarization or something like that?
That's a part of it, but that's not really the. Okay, well, keep going. Let's see where you go with this.
No, you scared me. I don't know. I think it's
All right.
Because of ventric.
So let me help you out. Let me help you out. Just watch what I do for a second. So here's a cell, right? All right. The heart is not getting blood flow, so these cells are starting to die. Remember, they started off with ischemia. That's lack of blood flow. Then we have inflammation. We're going to have injury. We're going to have infarction and then necrosis later. How does all this happen? Okay. So here's your cell. When the cell is at rest, it has a very negative charge on the inside. Okay. Now, during
Right.
the phase called depolarization, so there's a phase called depolarization, there's a phase called repolarization. During depolarization, here's what happens. Sodium from the outside with its positive charge goes in through a sodium channel. Okay, so let's put some sodium in. Boom. Now we got sodium in. And sodium has a positive charge. And so when I take a positive charge from the outside and push it in, what does the charge on the inside become? Positive or negative?
It becomes positive.
Okay, so it becomes
because
positive.
potassium comes out.
Okay, hold on.
Right.
Hold on, show off. All right,
Whoa.
this is good. Let me go to the next one. Then the other thing that happens is we have calcium that goes in through a calcium channel. All right, let's put calcium in with its two positive charges. So now we've got calcium. So we got all this positive charge going into the cell. How did the cell become more positive? Sodium and calcium, both of them have a positive charge. They both go inside the cell. The inside of the cell now becomes more positive. The word for that is called depolarization. But depolarization is not an EKG thing. Depolarization is a cell physiology thing that happens to every cell in the body. Skin cells, heart cells, muscle cells, brain cells, all cells do this. And then what happens is then potassium starts leaking out of leaky potassium channels. Oh, actually, let's do it on this one. So originally, there was potassium on the inside of the cell, but this potassium starts leaking out, and now we get potassium on the outside of the cell. Now, if we get too much potassium leaking out on the outside of the cell, some of that potassium can make its way to the bloodstream, and now we have hyperkalemia. Okay? Now, but what's supposed to happen? How does that sodium, okay, so what happens is the sodium, originally the sodium was on the outside. And originally the calcium was on the outside. But they'd end up on the inside. Well, how do they get out? So what's supposed to happen is there's this thing called the sodium potassium pump, and it pumps the sodium out. In fact, it pumps 3 sodiums out, 3 Na plus, and then it pumps 2 potassiums back in. Okay, now, so that was just background information. Let me get to the part of why do you end up with ST elevation? Have I lost anybody? Is everybody still with me? Give me a thumbs up. Okay. Now, how do you end up with ST elevation? Because once this cell starts to die because of a lack of blood flow, what happens is the pump right here, the sodium potassium pump, it quits working or it doesn't work as well. Does anybody know what this thing needs for energy? So it's called the sodium potassium ATP ACE. So what does it need for energy? Somebody tell me. If it's called the sodium potassium ATP ACE,
ATP.
what does it need for energy? Oh, you got it. Okay. Smart cookie. So it needs ATP. But when you're in a low energy state because you have a lack of blood flow, you're running out of ATP. So let me show you what happens. This is so cool. When you now run out of ATP, the ATP ACE doesn't work. So what's going to happen is now the sodium that was supposed to get pumped out of the cell, it stays on the inside of the cell. Now, watch what happens. So let me just clean this up a little bit so you can see. So let's say we put sodium. We put all this sodium that cannot get out. It's stuck in there because the pump is broken. And the job of the pump is to pump the sodium out so it can go back to where it came from. But now the pump is down. So we've got a backup. So all this sodium gets trapped in the cell. You know what sodium likes more than anything? Its cousin, chloride. So now wherever there's sodium, we're going to now have chloride. And when I put sodium and chloride together, what do you call that? What is it called when it's sodium and chloride? What is that called? Type it in the chat. It's called salt. So table salt is sodium chloride. So now what I just said is sodium got trapped in the cell. It brought in its cousin chlorine. When those two get together, when we have sodium and chlorine together, we now have sodium chloride, also known as salt. And you know what does salt like more than anything? Water. So now water gets into the cell. And if I keep pumping water into the cell, what happens to the size of the cell?
Swells.
It gets bigger.
It gets bigger.
That is called inflammation. That is how inflammation happens in every part of the human body. We just call it different names for different body parts. If it's in the brain, we say increased intracranial pressure. If it starts affecting the optic disc, we call it papilledema. If it's in the pancreas, we call it pancreatitis. If it's in the heart, we call it carditis or myositis. If it's in the GI tract, we call it irritable bowel syndrome or Crohn's disease. But it's inflammation, 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 and this happens all over the human body. So back to the question of why do we have ST elevation in a STEMI? It's because when all this stuff starts happening and all this positive charge gets trapped on the inside of the cell, in the EKG paper, whenever the EKG senses that there's positive energy flowing, everything points up. When there's positive energy flowing on the EKG paper, everything points up. When there's negative energy flowing or no positive energy, everything points down. So in an EKG, when all this positive stuff is trapped on the inside of the cell, that manifests in a positive deflection in the EKG with a positive ST segment or ST segment elevation. Now, I know that was a lot. Who wants to take a stab at seeing if you can repeat this? Garrett, you got it? You want to try it, Garrett?
I can try it.
Yeah, all right, my man, I like it. I like the enthusiasm. Give me a moment to find you.
All right.
Garrett, there he is. Okay, let's put Garrett in. And let's go, my man. Hit me with this. Tell me about, give me the whole thing. Give me stable versus unstable, or give me angina versus MI. Start there.
Angina is the cells become ischemic and then they become hypoxic, which leads to respiratory distress and leads to respiratory failure, respiratory arrest, and then cardiac arrest.
Okay, so let's start with this part. So the cells become ischemic. That's due to a lack of blood flow. Okay, now what is angina versus infarction? Because both of them have to do with this. But
angina, the blood vessels will swell or close up, and then
so it's not that the blood vessel closes up, because if it closes up, we got no blood flow. So angina, or especially stable angina, it's where you have a plaque that stays in place and it's kind of messing with the blood flow, thus causing ischemia. But most of the blood vessel is still getting blood. I mean, blood is flowing through most of the blood vessel, so most of the tissues are okay. That's why you only have pain for like 5 minutes. But then as soon as they rest or they take a nitro, the pain goes away because now we've got more blood flow. That's angina, or that's stable angina. What is unstable angina?
It's where it doesn't.
So what's this situation?
The plaque bursts.
Yeah. So the plaque, you have a ruptured plaque, and now that clot starts to move. Okay.
Yeah, and then none of the heart gets blood flow.
Okay,
Or
so
all
now
three layers
that
of the
that
heart.
plaque is blocking the blood flow. Okay, so we have an interruption in blood flow. And now instead of just having ischemia, we're going to progress to inflammation. We're going to go to injury, and then we get all the way to infarction. And if we don't do something about it, the next step is necrosis. That's where the cells die. And when enough cells die, you die. Okay?
Yes, sir.
All right, so now let's talk about what is the difference between an NSTEMI, where you have ST depression, and a STEMI, where you have ST elevation. What is the difference in these two situations? First, let's go with
The
NSTEMI.
the NSTEMI is where you'll have 70% of a blockage,
Okay, that's where
and
symptoms start, is when you have at least 70% of blockage in blood flow. So we're only getting 30% of blood flow. Okay, keep going.
yeah, and the first two layers of the heart are getting blood, but the innermost layer is not, and it's called a
Endocardial.
subendocardial
Okay, because this
infarct.
innermost layer is the endocardium, and it's beneath that,
Endocardium.
so it's subendocardial.
Okay.
Okay, so a
And
subendocardial
then
infarct. Great. Now tell me about a STEMI.
a STEMI is where no layers of the heart are getting blood, and it's a
Mural.
transmural
Okay,
infarct.
so we have
Sorry.
at least 90% blockage in a coronary artery. We only have like less than 10%. Sometimes it's 100%, but at least 90% of it is blocked. So there's like no blood flow at all. So the entire heart suffers, all three layers of the heart. And the word for that is transmural. Okay. Tell me again, why do we have ST elevation though? Like, why does the line get elevated in a STEMI? What's
When
going on at the cellular level that makes the line go up?
the pump from depolarization to repolarization fails,
Okay. What's the name of
which
that pump, by the way?
the ATP pump. I can't remember the full
Okay.
name
All right.
of
Let me help
it.
you out because you just
All
can't
right.
be making up stuff. So it's going to be the sodium, potassium, ATPase,
Okay.
or also known as the sodium potassium
ATPase.
pump. What's the
Okay.
job of the sodium potassium ATPase or the sodium potassium pump? What's the job of it?
To release the positive.
Okay, so it pumps. So ATPase, that's an enzyme. So it's a pump,
Mhm.
and it pumps sodium one way and potassium the other way. Which way does the
Okay.
sodium go?
The sodium goes up,
So it goes out of the cell.
out.
And which way does the
Okay, and
potassium
potassium
go?
comes in.
Potassium goes into the cell. Here, let's put them in. Let's change my colors to match. Potassium goes into the cell. How many sodiums get pumped out? 3. How
3.
many potassiums get pumped in? 2.
3.
2.
Okay.
So it's 3 sodiums out, 2 potassiums in. But what happens when
Okay.
the pump fails? Now the sodium gets
sodium
trapped
gets
where?
trapped
Where?
in the cell.
Sodium gets trapped in the cell. Sodium has a
Mhm.
positive charge. What does sodium attract with it? Because it says, hey, don't leave me in here by myself. Call my cousin. And who's its cousin?
Chloride.
It causes its cousin chlorine. When those two
Chlorine.
hook up together, when sodium and chlorine hook up together, we now have sodium chloride
Sodium chloride or salt. Yeah.
or salt. And who does it attract?
Water.
Salt attracts water. It's real thirsty because both of these are real thirsty. So they attract water. And as we get more and more water inside the cell, what happens to the size of the cell?
It increases.
The cell size increases. Now, let me show you what happens. So let's say we take a cell. All right, hold on. Follow me here. Let's say we have a cell, and then the cell starts getting bigger. And then eventually it just gets bigger and bigger and bigger. That's called inflammation. But eventually, once it gets so big, it starts getting damaged. Now, watch what happens next. Let's damage the cell membrane. Now, for instance, let's say there were some enzymes in here, like troponin. But now that we have membrane damage, this troponin starts leaking out. And this troponin leaks out into the blood. So this is why in the bloodstream, here, let's put it in yellow. We have more troponin that starts leaking out into the blood. So this is why one of the things that's going to happen in a STEMI, or it can also happen in a non-STEMI, is we have elevated cardiac enzymes. Where did they come from? These enzymes were originally inside the cell in small numbers, but then they start leaking out, and they all make their way into the blood. So now when we draw a lab value called a troponin, we see troponin inside of the blood. That tells us that the membrane has gotten damaged. Does that make sense?
Yes, sir.
Okay, so this is why one of the hallmarks of a STEMI or non-STEMI is we're looking for elevated troponin. And in just like stable angina, they're probably not going to have elevated troponin. Okay, and so we're going to check a troponin, for instance, at the 2-hour mark. Well, at time 0, we're going to check it about 2 hours. We'll check again at like 4 hours. And if their troponin is like, if both of these numbers, the 2-hour and the 4-hour troponins are elevated, they just bought them a hospital stay. And they definitely need a cath lab too. Okay, does that make sense?
Yes, sir.
How is your understanding of STEMI versus non-STEMI?
Much better now.
Much better now. Okay, the pictures help?
Yeah. Yes, for
Okay,
sure.
cool. All right, so that was the first question. I know that was a long question, but that's why I wanted to start with that one. This is actually a really big topic, and it was the question on angina versus MI. This is a really heavily tested topic to know. Does anybody have any questions on that before I go to the next? Oh, no, I'm sorry. There's more to talk about here. Let me just keep going for a minute. So, angina, STEMI, non-STEMI, is it going to be primarily an oxygenation problem, ventilation problem, or perfusion problem? Everybody type that in the chat. If it's a blood flow situation, okay, that's a perfusion problem. Now, how do we treat it? Well, our main treatment for acute coronary syndrome, whether it's called stable angina, unstable angina, MI, we're going to kind of treat it all the same because we don't have lab values to necessarily tell us. The only thing we have is the patient who's complaining of something, and we have an EKG to look at. So our main treatment is going to be Avon. Some of you may have learned Mona, but Mona, I don't want you to use it because it's definitely the wrong order. But Avon is something you can use because it's actually the order that you would do stuff in, or that you could do stuff in. So the A stands for aspirin. The V is for vital signs. The O is for oxygen if needed. So that's going to be if they're showing signs of respiratory distress or hypoxia. Because going back to what we just said, respiratory distress and hypoxia are oxygenation problems. And so if they have an oxygenation problem, they need oxygen. Okay. If they don't have an oxygenation problem, they probably don't need oxygen. So we don't just automatically give oxygen to everybody having a heart attack or everybody having a stroke. It's only if they need it. The reason we don't automatically give it to them is because high dose oxygen for a long time can actually cause the blood vessels to constrict. So in the heart, it can cause vasoconstriction in the heart. That would make their heart attack worse. In the brain, it can cause cerebral vasoconstriction. That can make their lack of blood flow to the brain. So if they're having a stroke, that can make the stroke worse. Kayla, did you have a question? I see your hand up.
Yes, I did have a question.
Go for it.
It was just in regards to the symptom part when it came to the angina. I was just curious, now would a patient only be feeling symptoms during the unstable angina portion of it?
Primarily.
Okay.
Well, no, I can't say that. They can still have symptoms during stable angina. It's just that in stable angina, what makes it different is that the pain is relieved by rest or nitro quickly. So they sit down, they calm down and rest, or they take a sublingual nitro and then the pain goes away. That was a stable angina. If they sit down and rest or take a nitro and the pain does not go away, it's probably unstable angina.
Gotcha.
Okay. Did that answer your question?
Yes, it did.
Okay. All right. So now let's go back to this part. So the first thing that you're going to do is aspirin, unless it's contraindicated. Then we're going to get vital signs, because one vital sign that we definitely need to know is their blood pressure. Then we're going to give them oxygen if needed, and then we'll give nitro. Okay, let's talk about aspirin. What does the aspirin do? So when it comes to these meds, we need to know a few things. You don't need to know everything about medications, but you need to know a few things: the indication, the contraindication, the class, and the mechanism of action. Now, in real life, you also need to know the dose. You need to know like the dose and the route. For testing purposes, they're not going to ask you too much about dosages unless it's standard, like just ACLS kind of dosages. But aspirin, what's the indication for it? So the indication for aspirin is going to be acute coronary syndrome or chest pain. Now, all patients having a STEMI don't have chest pain. Like, for instance, you've heard me talk about the triad of elderly. You've heard me talk about the triad of elderly, female, diabetic. Okay? So you got a 60-year-old female diabetic or 65-year-old female diabetic. They often don't feel pain because of the diabetes. It destroys their nerve endings, so they can have like central or peripheral neuropathy. So they have pain, they just don't feel they have pain. So this patient especially may not actually have chest pain, but they may in fact be having a heart attack. Point you want to know: anytime you have this triad, or at least two of the three, so elderly female, female diabetic, elderly male diabetic. Definitely, if you have elderly female and diabetic, you definitely need to take this patient a lot more seriously. So even if they just have, hey, I just don't feel right for no real reason, go ahead and do the 12 lead. So my rule is any complaint above the belly button, do a 12 lead. That means abdominal pain, epigastric pain, just sick for no reason, chest pain, breathing problems, altered mental status, seizure, stroke, any complaint above the belly button, do a 12 lead. I can't tell you the number of STEMIs I've caught, and the patient was just saying, I just don't feel right. And I did a 12 lead. I'm like, oh, I see why you're not feeling right. I need you to be really, really calm. I want you to sit really, really still. I'm going to do all the work for you. Hey, we got a STEMI alert. I need cath lab on arrival. Okay. Now, excuse me. Any complaint above the belly button, go ahead and do your 12 lead. Now, what is the contraindication for aspirin? When would I not give it? So here's what we're going to do. This is what I say. When you come into the house, give them that aspirin. You want to come in and say, bam, take this aspirin. We come in and say, bam, take this aspirin. Why do I say that? Because we're going to say, bam, take this aspirin unless you have bleeding, allergies, or you've taken the max dose. Bam. So bleeding, you have a real allergy to it, or you've already taken the max dose. Okay, you've already taken 324 or 325 milligrams. All right, what is the class of drug for aspirin? What's the class? It has 4 classes. What is the main class? Just type them in the chat. Okay, antiplatelet or antiplatelet aggregator. That's how you want to know it. Antiplatelet means don't make platelets. That's not what it's doing. It makes the platelets still are made. It just prevents the platelets from sticking together. That's called platelet aggregation. So it's antiplatelet aggregation. Okay. What's the next class of aspirin? Okay. Anti-fever. That's called antipyretic. All right. Billy's showing off. It's an anti-inflammatory. No, I love it. It's an anti-inflammatory and, okay, the word for pain, that's going to be analgesia. So it's an analgesic. Okay, so it's used to take care of pain. Now, how does it work? What's the mechanism of action for aspirin? All right, bonus points for who gets this one. Type it in the chat, quick. Come on, guys, I got a lot to cover. All right, what's the mechanism for aspirin? It doesn't stop clots from forming. Remember, it stops platelets from sticking together. That's a different situation. All right, my man Billy, he's on a roll. it irreversibly binds to COX-1 and COX-2. All right, that's cyclooxygenase 1, cyclooxygenase 2. Those are things that happen along what's called the prostaglandin synthesis pathway. For those of you at the pro level, check out the Coach Joshua's 5-star drawing study guide. I literally draw out the whole pathway for you. Okay. And then the dosage is going to be 162 to 324 milligrams. All right. O2. Why do we give oxygen? Because if they have a lack of blood flow, if we have a lack of blood flow and oxygen gets traveled through the blood, that means we're eventually going to have a lack of oxygen called hypoxia. So that's why we're going to give them oxygen. So the indication for that is going to be hypoxia, respiratory distress. Okay. Contraindication. There's no real contraindication to it in an emergency. I don't care about them having a hypoxic drive, if they have COPD, if they're in respiratory distress or hypoxia. Even if they have severe COPD, they still get oxygen. Because if I don't give oxygen, then I'm going to not only have hypoxia, I'm going to have cardiac arrest. Okay, so we never withhold oxygen to somebody in an emergency. We're just mainly concerned about getting, like a COPD patient, getting high flow O2 for a prolonged period, like hours. But in the time that most of you are going to be with the patient, even if you have them on a non-rebreather at 15 liters per minute for the next 30 minutes, they're going to be okay, or they'll be better than dead. Okay, so no relative contraindication for, or I'm going to say no absolute contraindication. All right, the class of oxygen, that's going to be an elemental gas. All right, mechanism, it binds to hemoglobin. Binds to hemoglobin. All right, and the dose depends on the delivery device. Nasal cannula is going to be what? Hey, just unmute for me. Okay, nasal cannula is going to be 1 to 6 liters per minute. Good job, Eric. Now, what if it's a capno nasal cannula? Okay, it's going to be 1 to 5 liters per minute. What if it's a non-rebreather? Non-rebreather, what you got? Okay, 10 to 15. I just say 12 to 15. And what if it's a nebulizer? Oh, okay. 6 to 8. That's right. 6 to 8 liters per minute. Don't use a nebulizer at 12, 15 liters per minute, because it's like albuterol for them, albuterol for you, albuterol for your partner. It's albuterol for everybody. You get an albuterol. You get an albuterol. Okay. All right. So now what if we're going with CPAP? That just depends on your device. It could go all the way up to 25 liters per minute, depending on what kind of CPAP machine you have and what you hook it up to. If it hooks up to the Christmas tree or if it hooks up to the 50 PSI port on the side of the oxygen tank. It just kind of depends. Okay, now let's go over nitro. Nitro, why do we give nitro in the setting of acute coronary syndrome? What's the indication? There again, it's going to be primarily, it's going to be acute coronary syndrome or chest pain. What's the contraindication for nitro? Okay, so low BP, so hypotension. Okay, what else? Okay, so ED meds, and specifically, I don't want you to call them ED meds. I want you to call them PDE5 inhibitors. Now, they are treated, I mean, the condition is ED, that is correct, but the class is, so the indication of those is for erectile dysfunction, but the class is called phosphodiesterase 5 inhibitor, so PDE5 inhibitor. How do we recognize the PDE5 inhibitors? What's in their name? Nice. Okay, Billy. Man, Billy is on a roll. Okay, they end in "feel." So the main ones, the trade names are Viagra, Cialis, and Levitra. Viagra, that's going to be sildenafil. Sildenafil. Cialis, that's going to be tadalafil. Levitra, that's going to be vardenafil, but they all end in "feel." So they make the person hopefully feel good. Okay, that's their class. What's the mechanism of action for nitrates? How do nitrates do what they do? So what's the end result of a nitrate? When you give somebody a nitrate, and this is why you cannot give them if they have low blood pressure or if they take a phosphodiesterase 5 inhibitor, okay? Man, we got to give it to Billy tonight. He is on it. So the end result of a nitrate is it's going to cause venodilation. What does that mean? It dilates a vein, okay? Or it can cause vasodilation. What does that mean? It dilates a what? Brendan, I'll come to your question in just a moment. What does a vasodilator dilate? A venodilator dilates a vein. What does a vasodilate? Okay, so that's going to be an arteriole, not an artery. It does dilate arteries, but it's primarily arterioles. Okay, those are smaller than arteries. Okay, now how does it do that though? How does it end up causing venodilation or vasodilation? Eric, you want it? Don't embarrass me now. You want to try it? Oh, come on. I got to put him in. Let's go, Eric. What you got? Hold on. All right. What you got? Can you unmute for me?
I have absolutely no idea. I'm trying to figure it out right now.
Okay. All right. Let me help you out.
Let's
It's
see.
no problem. I got you, my man. Okay.
I
So
was
the
trying to
mechanism of
erase
action of
Billy.
nitrates. Here we go. When I give a nitrate, so this nitroglycerin, it gets converted to nitric oxide. Okay. Then the next thing that's going to happen, so it goes this way. Nitroglycerin gets converted to nitric oxide. That's going to
the
activate
GAMP.
something called guanylate cyclase. That's an enzyme. That's going to increase the activity of something called cyclic GMP.
GAMP. Okay.
No, cyclic
GMP.
GMP. So CGMP. And then that is going to cause, so this whole mechanism is what's going to lead to venodilation and vasodilation. Okay, now, why do we care? If I dilate the veins, let's dilate the veins. So here's our person. All right, so hold on. Here's our person. And let's put these veins down in the feet. Okay, let's dilate these big veins in the feet. Let's make them really big. So now that means it's going to hold a whole lot of blood down in the feet. Well, if I put a whole lot of blood down in the feet, that means blood does not come back up to the heart because it's down in the feet. Okay.
Right.
And now if I can't get blood to the heart, what do I call that? So if blood doesn't make it to the right side, it doesn't come here, it doesn't go there, it doesn't make it here, and it doesn't come here. When I don't get blood over here in this left ventricle, what do I call that? That's called a decrease. So the venodilation causes a decrease in preload. Preload is the volume of blood that comes into the heart. And if I don't have blood coming into the heart, blood doesn't come out of the heart. So preload is volume coming into the heart. But if I don't have it coming in, it also doesn't go out. That's called decreased cardiac output. So one complication of nitro is nitro decreases preload, nitro decreases cardiac output. Now, what if I dilate the arterioles? So let's dilate these. Let's dilate these. So now when I stretch out these bad boys, the resistance inside this blood vessel, when I make it bigger, do I have more resistance or less resistance if I got a bigger pipe? So like if I have a small
Less
pipe,
resistance.
Say it again.
Less resistance.
I'm going to have less resistance because it's a lot of room. So they're not all like cramped in there. If I make the pipes bigger, I have less resistance. And when I decrease the resistance by dilating the arterioles, I also drop the blood pressure. How does that happen? Well, let's prove it. Well, there's one equation for blood pressure. We know that blood pressure equals heart rate times stroke volume times systemic vascular resistance. When I decrease the resistance, I decrease the blood pressure. So this is how their blood pressure ends up dropping. Now, why do we not give it to them if they're taking phosphodiesterase 5 inhibitors? Because phosphodiesterase 5 inhibitors also cause this to happen. So if they're taking a medication that drops their blood pressure, and then I give them another medication that drops their blood pressure, I really drop their blood pressure, and now I put them into shock. Does that make sense?
Yeah, that makes sense.
Okay. You seem to have a moment there. You like that?
Yeah, it was moment.
Am I cooking, man, or what?
Yeah, you cooking. Yeah, you cooking. Yeah, you cooking.
All right, so run that back. Give me that back again. Tell me how nitrates work.
All right, nitroglycerin works. It converts to nitric oxide, which converts to
that's called guanylate cyclase.
Okay, guanylate cyclase, which also converts to CGMP.
Yes, cyclic GMP.
Cyclic GMP.
Okay, and then the end result of all that whole mechanism is going to be what two things?
Venodilation and vasodilation.
Okay, let's say if I just dilate the veins, and that's actually the major effect, is dilating the veins even more so than dilating the arterioles. Let's say I dilate the veins, what's going to happen?
You dilate the veins.
Where does all the blood stay?
It goes down to your legs.
Okay, especially if they're sitting. Now, blood due to gravity, all this blood is going to collect in their legs. That means it's less likely to make it back to what?
To the right side of the heart.
Okay, or to the heart. And if it doesn't make it to the right side, it doesn't make it to the left side. And if it doesn't make it to the left side, I have a decrease in?
It's in preload.
Decrease in preload. And if it doesn't make it in, it also doesn't make it out. So I have a decrease in cardiac. Decrease in cardiac output. Now, if I dilate the arterioles, what happens?
You're decreasing systemic vascular resistance, which also decreases
in the blood vessels all over the body. I have a decrease in systemic vascular resistance. In the blood vessels to the lungs, I have a decrease in pulmonary vascular resistance. So this is why nitrates and PDE5 drugs are also given for problems like pulmonary hypertension. Okay. So once I drop the resistance, whether it's the systemic vascular resistance or the pulmonary vascular resistance, when I drop those resistances, what also happens? I drop the...
You drop the blood pressure.
Okay, and if I give two things that drop the blood pressure, I significantly drop the blood pressure and put them into...
shock.
Check you out, my man.
All right, cool.
Okay, you like that?
Right. Yeah, I like it.
Okay, now, cool. So let's go to... Any questions so far for anybody? Is everybody understanding so far? Give me a thumbs up or a thumbs down. Okay. What about you, Kayla?
I'm good.
Okay. All right. Cool. All right. Now, let's say we give this patient some aspirin. All right. We're just going to keep going. Let's say we give this patient some aspirin and they take too much of it. Or let's say they already had some, they've been taking aspirin for the last 5 days because they've been in pain. And then you come in and give them some more aspirin because you didn't ask questions like, hey, do you have BAM, bleeding, allergies, max dose? You didn't figure out that they've already taken way more than they should have. What are two major complications of an aspirin overdose? We have an early situation that can happen, and then later we have another situation. When it comes to the acid-base disorders, what are the two primary disorders that happen with an aspirin overdose? What happens in the early stage? Let's go to Brendan. Your camera's not on, but can you hear me, Brendan? Or can you at least unmute? Brendan doesn't want to talk. Let's go to Brian. Okay, Brian, it looks like you're coming on.
Sorry.
So what happens in an early aspirin overdose?
Early aspirin overdose, metabolic alkalosis. Or sorry, respiratory.
Okay. So metabolic alkalosis? No, hold on. That's not right. Say that over.
Respiratory, sorry.
Yeah. Got me saying wrong stuff. So the first thing that happens is respiratory alkalosis. And if you guys were with me, 2 weeks ago or last week or whenever it was, I did a whole thing on acid base. Go back and watch that because I went a lot more in detail on acid base balance. That would be a great one to know. Okay, so the first thing that happens is respiratory alkalosis, but later, what does it progress to? Brian, you can still go.
Yes. Sorry, my guys are locking in. What was the question?
Respiratory alkalosis is what you get initially, but what do you get later?
It would be metabolic
Metabolic what?
acidosis.
Metabolic acidosis. All right. So now let's keep going with that. In a situation of respiratory alkalosis, how's the pH going to be? Is it going to be low or high? Compared to 7.4, is the pH going to be up or down?
So respiratory opposite. So it would be
Well, first of all, we start with the alkalosis part.
right.
So that determines, so the pH determines alkalosis or acidosis
Right.
first. So is the
So
pH for alkalosis going to be up or down compared to 7.4?
It'll be up.
It's going to be up. Okay. How's the CO2 going to be if it's a respiratory problem?
Respiratory opposite. So it'll be PaCO2 will be down.
Aha. So CO2 is going to be down. And how's the bicarb going to be?
Bicarb should be normal.
Okay. The bicarb may be unchanged. Bicarb may be normal. Okay, good. Now, what about in metabolic acidosis? How's the pH going to be?
So metabolic equal. So acidosis, the pH will be down.
pH goes down, so less than 7.4. How's the CO2 going to be if it's a metabolic situation?
CO2 should be normal, and the HCO3 will be down.
All right, so CO2 should be, it may be normal.
Neutral, I mean.
It could be normal, or it may not be if it's compensating. And what's the bicarb going to be?
Bicarb is going to be below 22.
Bicarb's going to be down. Nice. Okay. So what is our normal pH?
Normal pH will be between, I guess, like the sweet spot will be 7.4.
Okay. So 7.4 would be perfect, but what's the normal range?
35 and 45.
You sure?
7.35.
Okay, and that's different. That's different than 35. So it's
Right,
7.35 to 7.45 is our normal pH. Okay, what is our normal CO2?
Normal CO2 is 35 and 45.
That's going to be 35 to 45, except let's flip-flop the numbers. Let's put 45 on the left, 35 on the right. Okay?
Right.
And of course, that's measured in millimeters of mercury. And then what is our normal bicarb level?
Bicarb will be 22 and 26.
22 to 26. Good. Okay, nice. See how many things we can tie in with one little situation? All right, so in this, we started off talking about angina versus MI. Okay, we went through the whole thing about STEMI versus non-STEMI. We talked about why your troponin levels go up. It's because the membrane got damaged due to all this cellular swelling. How did the cellular swelling happen? Well, the pump quit working. So the sodium got trapped inside the cell. It attracted chlorine in there with it. Now we got salt in there. And now whenever you got a lot of salt, of course you got to have a lot of water. So water goes in, the cell continues to swell, the membrane gets damaged, now stuff starts leaking out. Okay? And when stuff starts leaking out, like troponin, when troponin now goes into the bloodstream, it's now measured in your blood and your enzymes go up. Does that make sense, everybody? Yes or no? Yeah? Okay, cool. Let's keep going. Now, there was another question on, or first of all, let's stop there for a second. Let me take some questions for a minute. Hold on. Let me change my screen so I can see you. Does anybody have any questions right this second? Or can we keep going? Keep going? All right, let's go, keep going. There was a question on lab values. So you're going to have to be a little more specific on that. But what I do want you to do is, especially those of you, the paramedic and advanced EMT, you have access to the comprehensive study guide. So if we go to the comprehensive study guide, actually on pages 125 to 129, there is a whole thing on different labs, but let's talk about probably the most important things to know. Okay. I literally teach a whole class on lab values alone. Like that's a whole multi-hour class. So that I'm not going to be able to cover all that tonight. But some things that you definitely want to know is you want to know a normal SpO2. Type it in the chat. What's the normal SpO2 value to measure oxygenation? Type that in the chat, everybody. A normal SpO2, which measures oxygenation, is we're going to go with 94 to 99%. Okay, cool. But just because it's normal does not mean everything is good. Examples would be carbon monoxide poison. They could have 100. Anemia, they could have 100, 99. They're not good. So the number, you have to take it into account with everything else that's going on. All right, what's our normal value for our end-tidal CO2? I want everybody typing in the chat. Okay, so our normal CO2 value, that's going to be 35 to 45 millimeters of mercury. I'm just going to write it as 45 on the left, 35 on the right. Okay, because of course, as these numbers go down, we have more alkalosis. As these numbers go up, we have more acidosis. Remember that when it comes to oxygenation, ventilation, perfusion, remember CO2 it tells us information about perfusion, but it also tells us information about the ventilation status. And CO2 behaves like an acid. If you've been around for a while, you've heard me say this 100 times, that too much acid is going to lead to acidosis. When we have acidosis, that's going to lead to vasodilation, which is dilation of the arterioles, and then ultimately that's going to lead to shock. Okay? What's our normal value for our blood glucose level? Okay, and different books will say different things there. I'm going to go with about 70 to 110 or 70 to 120. 70 to 110 is where I'm going to go. Okay, so once they get below 60, regardless of age, we're going to say they're hypoglycemic. All right, when it comes to knowing electrolytes, there's a whole list. Okay, like if you do a Chem 14, that's 14 separate values. But some big ones to know are the normal potassium level. So a normal potassium level is going to be, let's do that in blue, 3.5 to 5 is our normal potassium level. What's our normal sodium level? Type it in the chat, normal sodium level. And by the way, everything I'm mentioning is in the comprehensive study guide. So you can just do a search, and that's why I keep it as a live document so that you can easily just Control F or Command F to find, and you can just go straight to the page or look at the table of contents at the top. Our normal sodium value, okay, that's going to be, no, blanking is not the answer, but it is going to be 135 to 145. And that's going to be milliequivalents per liter. No problem, Eric. Okay, another value that is important to know is the H&H, the hemoglobin and hematocrit. So this is a function of how the red blood cells are doing. And this actually changes from male to female. Every lab is going to be a little different, but the numbers I want you to know are going to be around like 39 and 13. Or some books will say 42 and 14. But what you want to know is the first number here. This is your hemoglobin. No, I'm sorry. No, that's not right. This is your hematocrit. This first number is hematocrit, and this number is hemoglobin. The relationship of these is this number should be 3 times the other number. Okay? And they should always be in that 3-to-1 ratio. So for instance, let's say the hemoglobin is 12. What should the hematocrit be? 12 times 3 is 36. Let's say the hemoglobin is 11. 11 times 3 is 33. Let's say it's 10. 10 times 3 is 30. So they should always be in a 3-to-1 ratio like that. Okay. Now, at what point does this patient need a blood transfusion? Once this hematocrit, once the hemoglobin gets to like 8, so now the hematocrit is going to be approximately 24. At this level, they definitely need a blood transfusion. Okay. Now, when it comes to white blood cell count, so white blood cell kind of tells us how the likelihood of you having some kind of infection, whether it's a bacterial infection, a viral infection, we don't know just yet. But anybody know? I mean, I know the number, but does anybody know this before I say it? Okay. Anybody else? All right, now let me show you where we find all this just so that you can, 128. All right, I'm gonna go to the comprehensive study guide and I want you to, if you haven't used this, here, let me back up for a second. If you haven't used this comprehensive study guide, I really want you using it because there is so much information in this. And I don't cover all of this in the course because it's not important for me to cover everything, nor do I have time to cover everything. But what's more important is for you to know how to figure out the answer even when you don't know everything. Let's see. It's at the bottom. Oh, it's right here. So I have a whole section on like the top lab values to know. So our typical sodium level, that's here, let's blow this up so you can see it. Okay, so our typical sodium level, that's going to be 135 to 145. Our typical potassium, our normal potassium is 3.5 to 5. So glucose, I've got 70 to 110. And by the way, this is pronounced BUN, it's not BUN. So that stands for blood urea nitrogen. So the BUN and creatinine, these are levels that tell us how well our kidneys are perfusing. Hemoglobin, and so hemoglobin is this number. So it varies from men to women. Our normal platelet count is 4. That shouldn't be 4. Let me actually change that right now. That should be 4,000. It's 4,000 to 11,000. Okay, that's our normal white blood count. Our normal platelet count is 150, and that's 150,000 to 400,000. Okay, but I've got all these different levels for you to kind of review. It's not so much that you need to know all of this. Now, when it comes to questions about lab values, what's more important than you knowing the number is figuring out like what kind of symptoms the patient is going to have. And what I encourage you to do is spend a little time reviewing that lab value section because I go into a lot of detail there, especially for those of you at the pro level. You have access to that in the bonus resources. Now, I do want to keep going though for a moment. So we just went over some partial things about blood gases. We just went over pH, PaCO2, bicarb, some other lab values that happen in your arterial blood gas. It'll tell you like the anion gap, the base excess. I'm not going to go into that for now. Another question that came up. Oh, this is a big thing. Okay, Garrett answered 4,000 to 11,000. Okay, that's going to be a white blood cell count. Oh, by the way, I'm glad you mentioned that. When it comes to white blood cells, another value is if you see something called a CBC with diff, that means differential. And what that's going to do is not only is it going to tell you the red blood cell count, the white blood cell count in terms of how many white blood cells, but for instance, for the white blood cells, it's going to break it down even further as to how many of each type of white blood cell. So when it comes to white blood cells, we have 5 main types. The way I remember this is never let mom eat beans. Now, some people learned it as never let monkeys eat bananas. I just like to go with never let mom eat beans. So the N stands for neutrophils. These are types of white blood cells. Neutrophils, what do they handle? They handle bacterial infections. The L stands for lymphocytes. Okay, these are going to be your B cells and your T cells that help fight infections. The M stands for monocytes. Okay, monocytes are what are going to be needed for us to ultimately end up making some platelets. We also have the E is eosinophils. Eosinophils help with allergic reactions. They also help with parasites. And then the B for basophils, they're also involved in like allergic reactions and other immune situations. Okay? And all of this is in the comprehensive study guide. Now, there was another question. Let's switch gears now. There was a question that came up about OB complications. So for everybody, if you're taking the EMT, advanced EMT, especially for advanced providers at the AEMT level, you get a lot of OB questions. But for everybody, let's talk about the most important things you need to know when it comes to OB topics. Everybody good so far? Give me a thumbs up if we're good, or let me know if you have a question. Give me a hands up if you have a question. Thumbs up if we're good, hands up if you have a question. Brendan, what you got? Good or question?
No, I'm good.
You good? Are you learning, my man?
Yeah, trying to.
You trying to? Hey, well, what's happening? Do I need to repeat something? Do I need to go over something?
No, I'm good. I'm learning.
Okay.
Yeah, it's a
Don't
lot of
fool me
stuff,
now.
but it's just refreshing.
Okay, refreshing in a good thing, in a good way?
Yeah, in a good way.
Okay.
Yeah.
I mean, I think that's
Yeah.
the only refreshing.
Just trying to pass this paramedic test.
Say it again.
I was just trying to get to pass this the NRENT, the paramedic.
Yeah, but you don't want to just pass, my man. You want to pass and be great. Okay.
Right.
Yes, I know you want to
Yep.
pass, but I need you to pass and be good when you pass. Well, in fact, be great
Right.
when you pass. Okay. So
Right.
let's go over. So, Brennan, you're going to hang in here with me. Let's talk about some of these OB complications. Okay. You ready? Here, let's just pop you in so I can see you. All right. Let me find you again. All right. I need you to jump in the car with me. You ready for a ride? All right, let's go.
Yeah.
Let's talk about OB complications. So the biggest OB complications, this was somebody's question. I don't remember who asked me, but somebody asked this question. The biggest things you want to know is a lot of these OB complications, we can kind of quickly figure them out. All right, how do we figure out that it's probably an OB-related question? They tell you about a female within childbearing age. Okay, what's childbearing age? Well, that starts at the onset of puberty to menopause. Okay? Now, when does menopause start? We say that menopause on average starts by age 51 years or 50 and a half years. Okay? Puberty depends on the girl. What is the age by which menses should start? When should the female get her first period? Okay, it's going to vary for everybody. But when we get concerned is when the female has not had a period by age 15. Okay, if no period, no menses by age 15, now we're actually concerned. There could be primary or secondary amenorrhea that needs to be investigated. But 15 is the number you want to know. That's when it becomes concerning. So let's say you have a daughter or something and she hasn't had her period by 13, nothing to freak out about. Maybe hers will just come a little later. By 15, though, we're definitely concerned because the hormones should have surged by that point. It should have happened. All right, now, when it comes to a big complication is going to be vaginal bleeding when it comes to OB stuff. The way you want to think about this is time based on time, okay? So, of course, pregnancy is divided up into 3 trimesters, right? Each trimester is approximately 13 weeks. So the first trimester is from the time of pregnancy up to week 13. Starting week 14 to week 26, that's the second trimester. Week 27 to week 39 is going to be the third trimester. At what point is mom considered full term? Different books will say different things. Some say 36, some say 37, somewhere around there. Why do we want the baby to stay in the oven and cook as long as possible? Because at around week 34, some books will say 32, other books will say 34, but somewhere around there, this is the part where surfactant starts being made. Surfactant is that kind of smooth, detergent-like substance that opens up the alveoli to reduce the surface tension so that you get more gas exchange. But it doesn't even get made until the baby is about 32 to 34 weeks gestation. That's why we don't want the babies being born premature, is because their lungs are not fully developed. They don't have enough surfactant yet. So we need the baby to stay in as long as possible, but we don't want the baby staying in 41, 42, 43 weeks, because now we can actually have other types of complications. Okay, if we have vaginal bleeding that happens in the first trimester, the top 2 things I want you to know are a miscarriage. So that's going to be what's called a spontaneous abortion. Now, I know I use the term abortion. This has nothing to do with your personal beliefs or your judgment. That's just the medical term for a pregnancy that ends under 20 weeks. It's called an abortion. whether somebody goes to an abortion clinic or just happen, like if they go to an abortion clinic to do it or they do it through some back alleyway, that's called an elective abortion, or even if they do it at their doctor. Or if it just happened on its own due to the body, then that's called a miscarriage. But both of those are under 20 weeks. Okay. And there again, it's not for you to pass your judgment one way or the other. It's just the word. It's just what the word means. Okay. Now, if they have vaginal bleeding in either the second or third trimester, so after a week 13 or definitely after week 20, then it's probably likely to be some kind of placental problem. The main problems, and these are not all the problems with the placenta, these are the ones that you need to know at your level. The two main ones are going to be placenta previa and placenta abruption. You could also have placenta increta, percreta, accreta. For you just need to know placenta previa, placenta abruption. Okay? Brendan, what is placenta previa? What's placenta previa?
When it delivers, like too early. Right.
Okay, so here's placenta previa. So let's draw in a uterus. We've got ovaries. All right, we'll put in a vaginal canal. So placenta previa is where, so I have that in brown. Hold on. Placenta previa is where we get a preview of the placenta at the cervical neck. Okay? So as we go into the vaginal canal, there's the placenta there. So the placenta should be attached to the uterine wall. But instead, the placenta moved, and now we get a preview of it down low. That's placenta previa. In fact, I need to put that one in red. Placenta previa. Now, don't worry too much about the color. Don't worry about the whole bright red, dark red stuff. What you want to worry about is pain versus no pain. So placenta previa, is that going to be so that it's described as bright red and painless? All right, so good job, Brian. On the other hand, placenta abruption is where the placenta was supposed to be attached to the uterine wall, but it just abruptly tears, and now it's no longer attached. Okay, so in abruption, it's typically described as dark and painful. What I want you to know is the either pain or no pain part. Forget the color, because as that blood just sits, the color will change. So even if it started as bright red blood, it'll end up as dark red blood eventually. But what I want you to know is painful versus painless. So if they describe somebody with vaginal bleeding in the second or third trimester, you need to think placental problem. If it's painful, that's probably an abruption. If it's painless, it's probably placenta previa. Okay? Another thing that happens with OB, you want to know hypertensive emergencies in OB. Give me a thumbs up if you're still with me, everybody. Okay? Let's talk about hypertensive emergencies in pregnancy. You still good, Brendan, right?
Yeah, good.
Okay, here, I'll take you out of the box for a minute. So hypertensive emergencies in pregnancy, okay? We call it different things based on different time periods. If mom already had high blood pressure, she was already taking blood pressure meds, or maybe it wasn't diagnosed. But if she already had, if it wasn't diagnosed, she doesn't know it probably. But if she had hypertension before she got pregnant, it's just called hypertension. She's just hypertensive. But if today she gets pregnant and then she develops hypertension later, that's called gestational hypertension. Like if she's a diabetic after she gets pregnant, that's called gestational diabetes. If she has high blood pressure after she gets pregnant, that's gestational hypertension. That means it was brought on by the pregnancy. But that also should mean that once she's no longer pregnant, she should no longer have high blood pressure. Sometimes that doesn't happen though. Okay, so gestational hypertension typically, so it's after she gets pregnant. Now, but gestational hypertension can happen anywhere through any term of the pregnancy, first, second, or third trimester of the pregnancy. It can happen the whole time. The things that we are most suspicious for after 20 weeks is either preeclampsia or eclampsia. What's the difference? In preeclampsia, this is where you have hypertension in pregnancy, primarily after 20 weeks. Now, what are some symptoms or some signs? It can be things like pain, abdominal pain, nausea, blurred vision, headaches, things like that. Now, so if she has hypertension that's causing all these other problems, that's called preeclampsia once it's after 20 weeks. But if she has hypertension that's causing all these symptoms or signs plus seizures, then it's called eclampsia. So eclampsia is hypertension plus seizures. Paramedics, what's our drug of choice for eclampsia? Nice.
Mag.
It's going to be mag sulfate. Okay. Now, mag, give me 3 situations that we use mag for. Let me give you a hint.
Can I just say?
So these are our set. These are so ready, set, eclampsia. So we're going to have S is seizures. No. I'm sorry. That's no, that's not S. S is status asthmaticus. Status asthmaticus. That's where they have a prolonged asthma attack. The E is eclampsia. So that's going to be hypertension plus seizures. And then the T is going to be torsades. I mean, Billy is just showing out for real tonight. Nice. Okay. So some other complications that we worry about with OB patients are supine hypotensive syndrome. All right. Eve, what's your testing level?
Paramedic.
Nice. Perfect. So let's bring you in, Eve. I know you were just sitting there like, please, coach, call on me. Okay. I heard you. I got you. All right. So Eve, supine hypotensive syndrome, what is it?
Is when she lays down and the baby, the pregnancy puts a lot of pressure on
Okay,
the...
so here's mom with his big belly. She lays flat on her back, and then there's this baby inside, right? So baby's just out here swimming, just hanging, having a good time. But what is the baby pressing on? So the baby starts pressing on this inferior vena cava. And what's the job of the inferior vena cava?
I'm on a blank right now. Sorry.
That's okay. So the inferior vena cava is how blood comes. So let's do it this way. Let's take our heart here. And remember, blood comes into the, when blood first comes into the heart, the very first place that it has to go is the right atrium. The 3 ways that it gets there is one of them is here. That's the inferior vena cava. The other way is from the top. That's the superior vena cava. And then within the heart, it's called the coronary sinus. So we have an SVC, superior vena cava. We have an IVC, inferior vena cava. And then we also have a coronary sinus. That's just the venous drainage. That's the vein side. You have an arterial side and a vein side. That's the venous drainage inside the heart. But so now we have, let's put this baby, when mom is on her back, the baby is pressing on the inferior vena cava. So let's put a big baby here pressing on this bad boy. And now that prevents blood from coming back up to the right side of the heart. So could that be a problem if mom does not get blood to her heart? Eve?
I'm sorry, they're talking on the radio and I can't hear.
Tell them to shut up. We're busy right now. Okay. Okay. So if this baby is pressing on this inferior vena cava, it's going to prevent blood from coming back to the right side of the heart. And if blood doesn't get to the right side, it doesn't get to the left side. And if blood doesn't get to the left side, it doesn't go to the body. So if blood doesn't come into mom's heart, is that a problem?
Yes.
Yeah, because if blood doesn't come into mom's heart, it also doesn't get to baby. Make sense? Because
Yes.
it has to come to mom's heart so it can eventually pump back to the baby. Okay,
Mhm.
so supine hypotensive syndrome is where mom is laying on her back, and so she's supine, and it causes hypotension. So it significantly drops her blood pressure because you knock out the inferior vena cava, you prevent blood from coming to the heart, so you prevent blood from coming here. And when blood cannot come in the left ventricle, blood can't leave out of the left ventricle, and that's where it gets measured as blood pressure once it goes into the aorta. So if blood never makes it into this aorta, the body says, "Woo, I don't have any blood in here." And the machine registers as no blood pressure or low blood pressure. Okay?
Okay.
The blood is still in her body, but it's in the wrong place in her body. Okay? It's like stuck down in the legs and the feet. Okay? So that's
It's not
supine
circulating.
hypotensive syndrome. So what are we going to do about this? Eve? How are we going to
Put her in a position of comfort left.
Okay, so we're going to put her in on her left side. So that's going to be called the left lateral recumbent
Recumbent.
or left lateral decubitus position. Okay, both of those mean the same thing. But all we're trying to do is we're trying to get this baby off of the inferior vena cava. What if mom's in cardiac arrest and we got to do CPR on mom? What do we do it? How is CPR different when she's pregnant?
Well, we can't do the.
Say it's the same.
See, that's a question that I got the first time I tested,
Say it's
and I
it's the
actually
same.
believe it wrong.
Just say
It's the same, but I got it wrong.
You got it wrong?
Yeah.
Okay, so CPR, like mom's heart is still in the same place, whether she's pregnant or not. Like it's not like her heart moved down here somewhere. Her heart is still where it
No.
is. We still do chest compressions the exact same way. We just add one more step to it. And so CPR is essentially the same, pregnant or not. She still has a heart. So it's just like anybody else with a heart. The only difference is we may have to kind of take our hand and like this big uterus, we may have to displace it to the left side just to get the baby off the inferior vena cava. Does that make sense?
Yeah.
But the CPR itself is still the same as anybody else that you do CPR on. You do it the exact same way, the exact same hand placement. It's just you have somebody else take their hands and push the baby over to the left side to get this baby off of this inferior vena cava. So we're going to move the baby over here. Does that make sense? Okay. All right. So that was somebody's question. There was another question on, I think it was Teresa asked about hypothyroidism. Okay. This seems to be a big topic for a lot of people. I was actually doing a session with Brian today and we went over. Oh, Brian. Hey, Brian, you're there. Brian, where you at? Come back. Don't leave me now, Brian.
I'm here.
You want to take it?
All right. So
was that a resounding yes?
Yeah.
That's what I thought you said. All right. So Brian, we're going to cover hypothyroidism. You want to hit us with that?
So hyperthyroidism.
All right, let's take them one at a time. So first of all, let's start me here, because there's some people that said, "Hey, where is the thyroid even located?" What would you say?
Above the trachea.
Now, when you say above, I don't know what you mean. Above means like up here. Is that what you say?
No, like in the middle. Like in the middle of the airway.
Okay, so you want to say in front of. So that's going to be anterior. So it's anterior to the trachea. Let's put in a thyroid here. All right, let's put in a thyroid. So it's kind of this butterfly-shaped gland that sits anterior to the trachea. So let's put in a thyroid here, okay? Now, Brian is we actually just went over this today. That's why I'm picking on him. So.
Would you rather be a pirate, a cowboy, or a samurai?
All right, let's mute everybody. Okay, now Brian, unmute again for me.
Okay.
Okay, now there are these 4 glands on the thyroid, and what are those glands called?
Adrenal glands.
The what?
No, I'm thinking of
You just made up stuff. No, these are what are called the parathyroid.
parathyroid.
Para means around. So the glands that are around the thyroid, those are the parathyroid. So these are very important in regulating calcium. That and your kidneys are big players to regulate your calcium levels. Okay, so that's parathyroid. But this orange structure here that I'm outlining now, this butterfly shaped thing, that's called the thyroid. Now, the thyroid gland, so the pituitary up in your brain is kind of the master gland that's controlling all these hormones. But what are some hormones that get released from the thyroid?
So
what are the main lab values that we're checking?
We're checking for T3 and T4.
Yep, T3 and T4. Now, they provide what's called a negative feedback to something else. So when these are high, it makes something else go down. When these are low, it makes something else go up. What's that something else called?
TSH.
TSH, or thyroid stimulating hormone. So we use these values, primarily the T3. So Teresa, if you are there or if you see this in the replay, I think this was your question. So primarily, we're going to look at the T3 and T4 levels. Everybody type in the chat. When we're looking at thyroid level, what is the main numbers that we care about? Now, we care about a lot, but what is the main one? All right, it's going to be your T3, T4 levels. So when these levels are high, you have the condition called hyperthyroid. And in hyperthyroid, your T3 and T4 are high, but then the opposite is your TSH is low. Okay. On the other hand, in hypothyroid, your T3 and T4 are low, and your TSH is going to be high. Okay. Let's talk about hyperthyroid. So what is hyperthyroid? It's where this thyroid gland is overactive and it's producing too much T3, T4. It causes a lot of problems. Who gets this? Well, one of them is the autoimmune condition called Graves' disease. Okay? Graves' disease. So what happens with it? So you have, basically, you want to think of everything is amped up. So when I say everything like what? Well, we're going to have an increase in heart rate. We're going to have an increase in blood pressure. We're going to have an increase in heat intolerance. We're going to have an increase in metabolism. We're going to have an increase in GI motility. Now let's break all this stuff down. Well, if I keep jacking up my heart rate, it causes tachycardia. If I keep jacking it up, it can now send them into AFib with RVR, SVT, PSVT, any of the tachycardic arrhythmias, but it can also send them into VFib. Okay? That would be the worst case. Let me say. So Graves' disease is one cause. Another cause would be a toxic multinodular goiter. What's a goiter? It's where you have a big thyroid. So they've got a big lump in their neck. Okay. How can you get a goiter? Well, you could have Graves' disease. You could have some kind of medication that could do it. You could have an iodine deficiency. In the U.S., because salt is in all of our foods, it's less likely in the U.S. that somebody is going to have an iodine deficiency. But let's say somebody has no salt in their diet at all. They don't eat out at restaurants or anything. They could have an iodine deficiency, but in the U.S., it's less common. Okay, now, if I jack up my blood pressure, what's that going to lead to? Now that can lead to hypertensive crisis. So the blood pressure can get dangerously high, cause a stroke. Okay. If they have increased heat intolerance, that means that everybody else in the room is comfortable, but they're hot all the time. So they're constantly taking off their clothes. Now, if they have an increase in their metabolism, are they going to be skinny or fat? Are they going to be small or obese? They're going to be larger. I'm sorry. No. They're going to be skinny. If they have an increase in metabolism, they're going to be skinnier. Okay? If they have increased GI motility, if the gut is just working out of control, what's that going to lead to? That's going to be diarrhea. All right, so now they've got diarrhea. Okay, so that's how you want to think of hyperthyroid. You're not going to necessarily remember the numbers. You don't have to even worry about remembering it, but you need to be able to recognize the symptoms. Let's take you out for a minute, Brian. So the symptoms of hyperthyroid. Now, what's happening is the T3, the T4 levels go up, the TSH goes down. Who gets it? Somebody with Graves' disease, somebody with a toxic multinodular goiter. What's that? A goiter is where you have an enlarged thyroid, but you can either have these, like bumps in here. These are called nodules. Okay. Now, sometimes these nodules dangerously cause you to produce too much thyroid. That's called a toxic nodular goiter. But if you have one nodule, it's just nodular. If you have a lot of nodules, it's called multinodular. But if it's affecting your thyroid hormone levels, then we call it toxic. Okay. Okay. Some other signs that you can have are increased heart rate, increased blood pressure, heat intolerance, increased metabolism. So they're probably going to have diarrhea, skinny. They'll probably be tired, stuff like that. But tired doesn't really mean anything. Every chronic condition, you're tired. Like you don't really see people with any chronic condition and they're just super energized all the time. Most chronic conditions, they zap your energy because they're taking nutrients away from your cells. Okay, now let's talk about hypothyroid. Okay, who gets hypothyroidism? Well, it could be maybe you have another autoimmune condition. That's going to be Hashimoto. So Hashimoto thyroiditis. That's an autoimmune condition. Primarily affects females greater than 40 years. Okay. It can affect anybody, but more likely it's going to be greater than a 40-year female. And that's true for all autoimmune conditions, whether it's lupus, whether it's myasthenia gravis, Lambert-Eaton myasthenic syndrome, most autoimmune conditions, systemic lupus erythematosus, it doesn't matter. Most autoimmune conditions are rheumatoid arthritis. They're likely to affect females greater than 40. Who else gets it? Somebody who's had some kind of radiation, like they had throat cancer and then they got radiation, that could wipe out their thyroid, or they've had their thyroid removed. So they've had a thyroidectomy. So thyroid surgery. Okay. Now, in this case, you're going to have a lot of the opposite symptoms. So everything is down. So heart rate is down. Blood pressure is down. Instead of heat intolerance, they have cold intolerance. So they're cold all the time while everybody else is comfortable. So they're always having to put on a sweater or a blanket, stuff like that. Instead of diarrhea, they're probably going to have constipation. Both of them can have fever, or both of them can have chills, night sweats, high or low. They both can have fatigue, hair loss, dry hair. Those aren't really specific. Are they likely to have weight gain or weight loss if their metabolism slows down? Yeah. So this patient is likely to be obese. So one's likely to be skinny, one's likely to be obese. So we've got some very different symptoms that can kind of point to hyper versus hypothyroidism. Okay. Now, the big things that you want to know is the dangerous levels of both of them. When your thyroid level gets dangerously high, we call that, Brian, come on, what you got?
So then that's what I'm gonna have, like obviously like the moon face.
No. You're giving me cushions. We're talking about thyroid.
Thyroid.
Okay.
Yeah, it's obviously. Also, they'll have obese and skinny legs.
No, you're still giving me cushions.
Cushing's. Oh.
Okay, we're talking about thyroid. Cushions is a different organ.
Right.
Okay. All right. So you're tired because we went over this today. So
tired, yeah.
The dangerous. Somebody type it in the chat. What is the dangerous form of overactive thyroid called? This is really important to know because this is life-threatening. It could kill your patient. It's called a thyroid storm.
Coma?
No. All right. Take a break. All right. It's called a thyroid storm. The dangerous level of an overactive thyroid is called a thyroid storm. It's where your thyroid is storming out. It's spazzing out. You've got so much thyroid that your heart rate just goes through the roof. Next thing you know, heart rate's 200. Blood pressure's 200 over 120. Okay, so this can lead to all kinds of tachyarrhythmias. It can also lead to hypertensive crisis. The reason you want to know this is if you have a patient with all these kind of symptoms and their heart rate is dangerously high, their blood pressure is dangerously high, the biggest thing that you got to worry about is thyroid storm that can kill them, and we got to calm stuff down right away. Paramedics, you want to know that the drug of choice is a beta blocker known as propranolol. But it's a beta blocker. Because why do we give beta blockers? We give beta blockers for heart rate. We give beta blockers for blood pressure. So a beta blocker is going to help with both the heart rate and the blood pressure by stopping the beta receptor. Okay, so that's thyroid storm. The other thing that you want to know is the very dangerous side when your thyroid gets really low. And what's that called? Type that in the chat. So when your thyroid gets super high, just going crazy, it can cause a thyroid storm. What's our treatment of choice for that, Billy? Just unmute. I just said it.
Yeah, I'm drawing a blank.
That's okay. For thyroid storm, the treatment of choice is a beta blocker. The number one beta blocker to use is propranolol. All right, let's say that again for everybody. You got a patient with a thyroid storm. How do we treat it? Beta blocker. Which beta blocker do you get to use if you get to pick? Propranolol. You may not have propranolol. You're going to use whatever beta blocker you have based on your protocols. Okay? Does that make sense, everybody? So, Billy, again, what's the treatment for a thyroid storm?
Sorry, I missed it. We were getting dispatched to a structure fire, but I'm not going on it. I missed that part. I'm sorry.
Okay. So, did
Beta
you hear
blocker.
what I said?
I heard the beta blockers and then the propranolol. But
Okay.
after that, I
So,
missed
for
it.
thyroid storm, the treatment of choice is a beta blocker. If you get to pick, use the beta blocker known as propranolol. And the reason for that one is it's a non-selective that works on beta 1 and beta 2. Like some beta blockers, they either like beta 1 or they like beta 2. Propranolol is non-selective, so it works on both. It actually stops both of them. Okay? Now, the next question is what about the thyroid that's underactive, that's not working, it's not producing enough T3 and T4? What's the life-threatening situation of this called? And the reason thyroid storm in this situation are tested is because they're life-threatening, and you got to be able to recognize this on a test. But more importantly, you need to be able to recognize this in real life. Somebody type in the chat, what's the life-threatening low thyroid called? Anybody? Anybody? Is this thing still on? Okay, that's going to be a myxedema coma. That's myxedema coma. What is myxedema coma? It's a dangerously low thyroid. Okay. Why do you need thyroid? Or why do you need thyroid hormone? It's what's called a permissive hormone. It's one of the hormones that and cortisol are the two hormones that help a lot of other hormones get made to keep you alive. This is why when somebody has a thyroid surgery, so they have either a hemi or total thyroidectomy, they have to be on thyroid replacement hormone for the rest of their life. So they're going to take a drug like Synthroid or levothyroxine for the rest of their life because they have to have, you got to have thyroid hormone to stay alive. And if you take out the gland that makes it, you got to supplement it with medicine, and they have to be on it every single day for life. Okay. So the dangerously low thyroid is myxedema coma. So you're going to have a really low heart rate. So significant bradycardia. Really low blood pressure, so dangerously low hypotension. So how would you treat this? Well, if you have really low heart rate with dangerously low blood pressure, if I put that combination together, we would call that symptomatic unstable bradycardia. What's our treatment for symptomatic unstable bradycardia? What's our treatment? All right, that's going to be transcutaneous pacing. Okay, so if you have a patient in a mixed edema coma, you probably need to be ready to go ahead and start pacing this patient. Okay. All right. Okay, so that's thyroid. Oh, there was another. Okay, so we covered hyper and hypothyroid. How do you guys feel about that? Josue, what's your testing level? Josue, you there? He's like, All right, hey, Brendan, I was talking to you last. Let's go back to Brendan for a minute. Brendan, can you come back in?
Yeah.
All right, so hit me with hyper versus hypothyroid. You ready? Can you do it without the screen?
Yeah, I can do it out.
Man, you got this. Let's go. Hit me with hyper and hypothyroid.
Hyperthyroid is going to be like the Addison's or whatever. It's just gonna be, everything's gonna be just up. Like the T3, T4 levels gonna be increased. Their just everything, their heart rate, all their vitals, their blood pressure increased. They're always gonna be like hot, uncomfortable.
Okay.
And then
give me some causes of hyperthyroid. So by the way, in hyperthyroid, what lab value is up?
The T3 and the T4 levels.
T3, T4 are up, and what is TSH?
It's going to be down.
It's going to be down. Give me some causes of hyperthyroidism.
Causes of hyperthyroidism is going to be
All right, so we said Graves' disease, toxic multinodular goiter, things like that. Okay.
Right.
All right, tell me what else you know about. So what's the dangerous level of hyperthyroidism?
There you go on the like thyroid storm.
Thyroid storm. All right, thyroid storm is a life-threatening medical emergency where your T3, T4 levels are dangerously high. You've got too much thyroid activity. And what's our treatment going to be? All right, come on now. You got your colleagues there. Don't embarrass yourself.
Yeah. Right. Yeah.
Yeah, what up?
Hey.
Sorry, I'm not trying to interrupt.
Yeah, just messing up my class. All right, keep going.
Treatment for some thyroid storm would
So
be
how you gonna treat it?
or else a beta blocker. If you don't
Beta
have
blocker. What's the beta
propranolol.
blocker of choice?
Propranolol.
Check you out, my man. I know you had to look, but you did good. You did well. All right, so let's go with let's see, Kayla. Let's put Kayla in the box. Kayla looks like she's ready to jump in. Kayla, let's go. You ready?
No, but yes.
Okay, I heard yes. Sounds good. Let's go. So tell me hypothyroid. So underactive thyroid. Let's start there. What you know about it?
Not much about it.
I just went through. Where you been? I just went through. Okay, so tell me what you know. All right, let's help you out.
Well, for
Okay,
hypo,
so let's start here.
Okay.
So the lab value that we measure primarily in thyroid conditions is what lab values? Just
The
look at the
T3
screen.
and T4.
Okay, it's me and you, okay? Nobody else. The world doesn't see us. It's just me and you in this. So what lab values are we going to look at again?
T3 and T4.
Okay, in hypo, so that means low. In hypothyroid, your T3, T4 levels are going to be up or down?
Low.
They're going to be low.
Down.
So if those levels are going to be low, your TSH is going to be?
High.
Nice. All right, you're on a roll so far. All right, we got about 10 more to go, okay? All right, so now give me some causes of hypothyroidism, some common causes. One of them is an autoimmune condition where your body starts attacking your own thyroid gland. And that condition is likely to affect females greater than 40 years old. What's that condition called? Just look at the screen.
Hashimoto.
Hashimoto. Yeah, you're good. You got it. So Hashimoto. Okay. Now, some other things that could wipe out your thyroid is, well, you don't have one. They took it out. Okay. Because maybe you had a goiter that was pressing on your airway. It got so big, it was causing compressive symptoms and stopping you from breathing. So they had to take out the whole thing. They had to do a total thyroidectomy. So they did thyroid surgery. By the way, if you've had a thyroid surgery, do they have to replace it with medications so your thyroid so that you can produce thyroid hormone? If you take out your thyroid, do they have to be on medicine for life? Say yes.
Yes.
Yes. And what's that drug called? So the med for it, that's going to be Synthroid, also known as levothyroxine. Okay? Levothyroxine. Okay? And they'll be on that for the rest of their life. How are the symptoms different from hyperthyroid? Well, think of everything going down. So heart rate goes down, blood pressure goes down. They're always cold. They're constipated. They're obese, things like that. Okay? They're very weak all the time. Some of you may have some of these symptoms. If so, have your doctor check your thyroid levels. A lot of people are underdiagnosed. I mean, a lot of people have it and they are diagnosed, but there are a lot of people who are not diagnosed or they're misdiagnosed with something else and it's actually a thyroid problem. Okay, what is the dangerous form of low thyroid called? Say myxedema coma.
Myxedema coma.
Oh, good. Myxedema coma. Check you out. Yeah, so myxedema coma. And when this is life-threatening because your heart rate goes down so low, your blood pressure goes down so low, it can send you into shock. How are we going to fix that, especially at the paramedic level? What are we going to do?
Pacing.
Yeah, this patient needs pacing. So what's your testing level, EMT or paramedic?
EMT.
Okay, that's okay. But you still want, so you're not going to be able to do things like pacing, but you still want to be able to recognize these endocrine emergencies. All right, good job. Okay, let's hit up Addison's real quick. So, all right, we're going to switch organs now. Everybody's still with me. Give me a thumbs up if you're still with me. Okay. Did we lose Eric? Did Eric say enough of this? Okay, so let's go. We're going to switch gears. We just covered thyroid. We talked about situations when it's up. We also talked about situations when it's down. Now let's switch to a different organ. We're going to travel down to, so we were up near the neck. Now we're going to travel down low and we're going to go down to the kidneys. But let's go above the kidneys and we're going to go into the adrenals. Okay? So this little kind of triangular shaped organ that sits on top of the kidney, so you have a left one and a right one, that's going to be your adrenal gland. Now your adrenal gland has two kind of sections. In fact, let's zoom in on this bad boy so we can see it. In fact, I need another page here because I'm getting so excited. Let's go into, so we were in the kidneys and now let's go into the adrenals. Boom. So here's what I'm going to do. I'm going to zoom into the adrenals. Boom. Here's our adrenal. Okay, now the adrenal gland has two kind of sections. All right, so this first section on the outside, here, this is called, what's in blue, that's called the adrenal. So anybody know? What's that called? Type it in the chat. What's the section in blue called? Adrenal cortex. This is the adrenal cortex. Now, the reason I'm going through this is heavily tested. And a lot of people miss these endocrine kind of emergencies. And a lot of people just they weren't taught it well in paramedic school. Your instructor just gave you a whole bunch of PowerPoints, but never, like, how many of you had an instructor draw pictures the way I do? Okay, probably most of you didn't. Okay. Pictures is my secret weapon. People look at me and say, they're like, Coach, you're so smart. No, it's just I got a lot of pictures in my head. And so I can pull up a picture at 3 o'clock in the morning, any time of the day, any day of the year, because I'm not remembering a PowerPoint. I just go to a picture and I'm like, oh yeah, let me just tell you what I see on the picture in my head. Okay, let's keep going. So we have the adrenal cortex and then the intersection of the adrenal, that's called the adrenal medulla. All right, so this part in the middle, that's called the adrenal medulla. Why do you care? Well, because in these two different sections of the adrenal glands, they make different hormones. Let's start with the adrenal medulla. Okay, the big hormones that get made there are hormones called so epinephrine and norepinephrine. All right, I think I talked about this in the previous thing, but I said, you know why it's called epinephrine? Because if we take the word epi means above, nephri means kidney, and epinephrine is made in the organ above the kidneys. That's why it's called epinephrine. All right. Now, in order to make epinephrine and norepinephrine, we got to have some other things like tyrosine, and tyrosine is going to eventually make dopa, and dopa is going to eventually make dopamine, and then dopamine is going to eventually lead us to epi and norepi. So those are what are called the catecholamines. But these are very important to keep you alive, okay? Like when you need your blood pressure to go up, we need epi. When you need your heart rate to go up, we need epi. We need norepi. We need these things. So if you have an adrenal problem and you wipe out this adrenal gland, think of all the hormones you're not going to make, okay? You're not going to have dopamine. You're not going to have, or that's a more of a neurotransmitter, but you're not going to have dopamine. You're not going to have epinephrine. You're not going to have norepi. It's going to be hard to stay alive like that. Okay. Now, out here in this other section called the adrenal cortex, we make some other hormones. So here's what happens. We have these kind of zones. Okay. So we have 3 zones here. And I'm going to start from the outside and work my way toward the inside. The way I remember this is one of the lab values that we check for kidney function is something called the GFR, the glomerular filtration rate. Well, I use those same letters, G, F, and R. Let's put a G, then an F, then an R. Notice they go from outside to inside. So the G is on the outside. So you have the G zone, the F zone, and the R zone. So the word for that is zona, and the one that starts with a G, so we have a G, a F, and an R. The G, that's going to be the zona glomerulosa. The F is the zona fasciculata. The R is the zona reticularis. You don't have to remember that part, but what's important is what do these different things make? The zona glomerulosa right here, it makes aldosterone. It makes the hormone aldosterone. Why do we need aldosterone? It's a part of the renin-angiotensin-aldosterone system that helps to regulate your blood pressure. Aldosterone tells your kidneys to hold on to sodium, to hold on to water, and to raise your blood pressure. Okay, so aldosterone is very important to regulate blood pressure. It's made right here. So let's put aldosterone there. So we have the GFR. The G makes the aldosterone. In the F layer, the zona fasciculata, so this layer right here, it makes cortisol. So your cortisol gets made in the adrenal cortex and the zona fasciculata. And then in your R zone, your zona reticularis, so right here, this one makes your sex hormones. So that's going to be things like testosterone, estrogen. Testosterone is also made in the testes. Estrogen is also made in the ovaries. But we need sex hormones for a lot of different things, especially secondary sexual characteristics. And also growth, things like that. Being able to get pregnant and all, like it's involved in a lot of stuff. Okay, now let's talk about, remember everything when it comes to these, all right, we're just going to cover this and then we'll go ahead and stop. Are you guys still learning though? Yes or no? Give me a thumbs up if we're learning. Okay, cool. Nice. Okay, so let's say you have we're talking about the adrenal gland. Remember, just like before, you can have problems where things go up or you can have problems where things go down. Let's talk about the up first. Let's say your adrenal gland it's going crazy. It's making all kinds of hormones. Well, for instance, one situation where you make too much aldosterone, that's called hyperaldosteronism. That could be due to a tumor that causes you to make too much aldosterone. Now your blood pressure is dangerously high. And a situation that's associated with this is going to be Conn syndrome, C-O-N-N, Conn syndrome. So situations where you have like too much aldosterone could be Conn syndrome or hyperaldosteronism. If your body makes too much cortisol, now it depends on who's doing it. Who's at fault here? If it's the brain up in the pituitary, so let's put a brain in here. And let's put a pituitary. So we've got the cingulate gyrus, we've got the corpus callosum, we've got the thalamus, we got the hypothalamus, then we got the pituitary. So let's just put it in green, this green. Pituitary. Okay? If this pituitary gland makes too much cortisol, then that's called Cushing disease. So if it's in the brain making too much cortisol, it's called Cushing disease. But if it's somewhere else in the body, then it's Cushing syndrome. Okay? So we could have Conn syndrome, that makes too much aldosterone. Conn makes too much aldosterone. Cushing disease makes too much cortisol. Cushing syndrome. Let's not put that in green. I don't want to confuse you there. We'll put it in purple. Cushing syndrome is too much cortisol, so increased cortisol. Okay, you want to know this. Cushing syndrome, how does this patient look? So they've got a round face. So that's called moon face or moon facies. Let's say this is their back. They've got this big pad on their back of their neck. So that's called a buffalo hump. Okay, but then they've got these really skinny legs. And then they got a big belly because they're obese. All right, so I say they're nice and cushy. So in Cushing syndrome, they're nice and cushy. So they've got things like a moon face, obesity, buffalo hump, skinny legs. Then they got stretch marks, so purple striae. Okay, so that's your Cushing syndrome or your Cushionoid person. That's Cushing syndrome. Okay, now, what if you have a situation where it's making too much norepi or epi? That would be like a tumor like pheochromocytoma. Okay, did you all learn that or no? Okay, skip it. Don't even worry about it. Okay, but you could have a tumor that causes you to make too much epi and norepi. The big things I want you to know is too much aldosterone, that's Conn syndrome, C-O-N-N, or hyperaldosteronism. Okay, too much cortisol, that's Cushing syndrome. If it's too much cortisol made from the pituitary, that's called Cushing disease. But if it's some other cause, then it's called Cushing syndrome. Okay, that's where your adrenals are overactive. Let's talk about when your adrenals are underactive. Well, think about it. If your adrenals are not working and your adrenals have to make all these hormones, if your adrenals are not working, is your aldosterone going to be high or low? Give me a thumbs up for high, thumbs down for low. Is your adrenal going to be high or low? I mean, is your aldosterone going to be high or low? It's going to be low. So if your aldosterone is going to be low, and aldosterone is what's responsible for keeping your blood pressure, now your blood pressure is going to be low. Cortisol. Is your cortisol level going to be high or low? In an underactive, your cortisol level is going to be low. Cortisol is how your body handles stress. That's why it's called the stress hormone. When your cortisol levels drop, you're not going to be able to handle stress well. You're not going to be able to help make epi, norepi. So your heart rate is going to go low. Your blood pressure is going to go low. Now, the worst form of that would be Addison's disease. Let's put that in blue. So Addison's disease. So this is where a patient has an Addisonian crisis. It's due to an underactive adrenal gland. So Addison's disease is where you have low adrenal activity or what's called adrenal insufficiency. It's not sufficiently working. So adrenal insufficiency or Addison's disease is where everything goes down, like heart rate, blood pressure, things like that. So just like, what was the situation that involves the thyroid where your heart rate and blood pressure go down? What's that called? What's the dangerous situation in the thyroid where things go down? What's it called?
Myxedema coma.
Myxedema coma. And then the dangerous condition in the adrenal is Addison's disease. Okay? Okay. Any questions on that? So we're going to stop here. I was going to go, there was another question about abdominal emergencies, but what I want you to do, because I was going to hit this, but I actually cover all of this in the comprehensive study guide. So I cover every one of these topics, and I want you to just go check that out. We could literally do a whole session on this. And then there was another thing about like how to recognize drug names. I think, Billy, this was your question, right? Let's hit this one quick. This is also in the comprehensive study guide. I keep mentioning comprehensive study guide. So if you haven't checked out the comprehensive study guide, make sure you check that out. Now, some drug categories that you definitely want to know are beta blockers. Beta blockers are used for things like blood pressure, heart rate, okay? And they typically end in law. Esmolol, sotalol, propranolol. Oh, wait a minute, propranolol. Wait a minute, I heard that. There's a situation that we use propranolol as the beta blocker of choice for. Type it in the chat. What's that situation called? Type it in the chat. Thyroid storm, yeah. Okay. So beta blockers are your laws. You want to know that. Another drug that's used for blood pressure is going to be your ACE inhibitors. These are known as your prils. Lisinopril, enalapril, enalaprilat. There are lots of prils, but the prils are your ACE inhibitors. We also have ARBs. These are angiotensin II receptor blockers. ARBs. They end in sartan, valsartan, losartan, candesartan. The sartans are your ARBs. Something else you want to know is both ACE inhibitors and ARBs cause a condition, or they can cause a condition called angioedema. Okay? You can have ACE inhibitor-induced angioedema. You can have ARB-induced angioedema. What's angioedema? It's where the tongue, the lips swell. Tongue and the lips swell. It can cause airway issues, airway compromise. So if this is your patient, they've been taking lisinopril for their blood pressure for 20 years. Today, their tongue is sticking out their mouth, is twice the size, and they're having trouble breathing. This is a life-threatening emergency because if that airway closes, you're not going to be able to tube them, and they're going to need a surgical airway. So you need to immediately be prepared for a quick and aggressive intubation. When I say aggressive, I don't mean be rough, but I mean you need to hurry up and get it done. Because if we don't get this tube, we're going to lose their airway and we're going to have to make an airway and we're going to slit their throat with a surgical airway. Okay? Now, this angioedema is different than the angioedema caused by, so angioedema can be like where the tongue swells, the lips swell. That can happen in an allergic reaction or anaphylaxis. The difference is what's causing the what's causing the angioedema. In anaphylaxis, the main problem is histamine. That's why we're going to use a drug like an antihistamine, diphenhydramine or Benadryl. But in ACE inhibitor-induced angioedema, the main problem is not histamine, it's bradykinin. Bradykinin. Okay? So your regular treatments that you would normally use for anaphylaxis don't work in this case because it's caused by a different problem. Okay? So there's a whole list of C1 esterase inhibitors that the hospital will give. You probably are not going to have those in EMS. Just know for this situation, they need a different set of drugs than for this situation. Both of them can cause the tongue and the lips to swell, but it just kind of, that's why you got to get a good history to figure out Is this an allergic reaction? Like, did they get stung by something? Did they have a bee or wasp or something, or shellfish, eggs, peanuts, chocolate, strawberries, some kind of allergy, medication allergy, things like that? Or did this just come out of the blue? If it just came out of the blue, you want to ask questions like, hey, do you take blood pressure pills? Do you take lisinopril, enalapril, any of the pills? Let me see your meds real quick, okay? And just know both of these situations are life-threatening, but we've got to be prepared for immediate intubation. Some other drug categories to know are like your calcium channel blockers. They're also used for blood pressure. They're used for a lot of other situations. Prince metal angina, things like that. These are like your penes. So like your dipines, amlodipine, nifedipine, nicardipine. Those are your, what kind of calcium channel blockers, Billy?
Calcium channel blockers.
Which kind? Because calcium channel blockers come in two flavors. What are they?
Oh, the
We have what are called
dihydropyridines
dihydropyridines
and yeah,
and non-dihydropyridines. Okay, dihydro and non-dihydro. Okay, but the dipines like nifedipine, nicardipine, amlodipine, those are the dihydropyridines that dilate blood vessels. And your non-dihydropyridines, they work on the heart muscle itself. Okay. You want to know things like your statins. These are cholesterol-lowering medications for the condition hyperlipidemia. So when your cholesterol is high, doctors like to put you on statins. However, so if any of you are on statins, they're not necessarily always safe because they can cause all kinds of things, all kinds of problems. They can totally destroy your muscles, lead to things like rhabdo, tumor lysis syndrome. So don't be so quick to just, like if your doctor wants to put you on a statin, which that's kind of it's just common, but sometimes doctors don't think, or sometimes doctors don't know, they're just doing what everybody else is doing. Like there are a lot of paramedics who they don't really know, they're just doing what everybody else is doing. We really want to understand the medicine. And what I'm saying is statins aren't always good. They can cause a lot of other problems. Because sometimes it's not that you need cholesterol. It's like this lowers the cholesterol, but sometimes we got to figure out, well, why did it go up? It may not address the actual problem that caused your cholesterol to go up. That's what really needs to be addressed. Okay. Some other things to know would be like loop diuretics. These end in semide, like furosemide, budesonide, the semides, those are loop diuretics. Your PAMs and LAMs, those are benzos used for seizures, anxiety, things like that. So your benzos typically end in PAM or LAM. Oxalopam, midazolam, things like that. Diazepam, lorazepam. And then some common antibiotics, we could go, there are about 1,000 antibiotics. But something you may see is drugs that end in mycin. So azithromycin, clarithromycin, vancomycin. Any of the mycins, they're going to be antibiotics. So this is a good list of commonly prescribed drugs that I would know. And these are easy, and they also get tested because they have common suffixes. Like we also, let's add something to the list. The ones that end in "phil," what are they? What's that class? These are going to be our PDE5 inhibitors that treat the condition erectile dysfunction. Okay, so how did you guys feel about tonight? And by the way, it wasn't that I was just randomly talking about topics. These were actual topics that got submitted on the form. And so I was answering questions that got submitted in the group. So what did you learn tonight? Let's go, Brendan. Brendan, just come off, everybody come off mute and just let's get through this quickly. Brendan, what did you learn tonight? What did you get out of this? Or what's your takeaway tonight?
I definitely learned everything we kind of talked about. Kind of just a big refresher being out of school for a little bit now. Just all the different drugs, all the different diseases and all that.
Okay. So here's what I'll do for everybody, because all of you are inside of the school community, so we don't have any outsiders tonight. What I will do is I'll take my notes. I'll take this PDF. It's my handwriting, so you just got to bear with me. But I'll just drop this whole thing as a PDF inside of school, so you can go back and kind of review this. And now what I want you to do is don't just take my notes. You want to be able to take what I've done and recreate it yourself. I always say, when you can teach it back and when you can draw it, that's when you understand it. So what I want you to do is I want you to take my notes and just take topic by topic and be able to teach it back and then draw a picture of it. When you can do both, that's when you actually understand it. Okay? Since you're there, what'd you get tonight? Kayla?
Oh, sorry. I don't know why it was on my thing. I learned a lot actually.
What did you really learn? Like, what was your aha moment tonight? You're like, oh, that's it.
Well, the aha moment was, to be honest, when we were talking about the Cushing disease and the Cushing syndrome.
Okay.
And when you mentioned like signs that you would see on a person, like the round face, the buffalo hump. Like I've seen people like that on polio. I'm like, and when you said that, I was like, what? So that's what that is?
Yeah.
It has to do
Yeah.
with the little,
Okay. And it's
you're
due
like,
to
yeah.
too much cortisol. And
Yeah.
the other thing that happens with too much cortisol is too much, it raises your blood sugar. So
Yep.
they'll also have hyperglycemia, and they're likely to have like that high blood sugar can end up. So when you have too much cortisol, it also raises your blood glucose level. That can put you into DKA, or it can put you into one of those hyperglycemic situations, DKA, HHNS, things like that. Okay.
Right.
So that's just another tie-in. Anything else? Any good takeaway tonight?
Definitely the recognizing the difference between the angina versus the
Angina, okay.
myocardial. Yeah, angina. Sorry. Then with the
Myocardial infarction.
myocardial infarction.
Okay.
Yep. And then being able to recognize the difference between those two.
Good.
Yeah.
Nice. Okay, cool. Eve, let's put you in.
Okay.
All right, let's change you out. Let's put Eve in real quick, and then we're gonna go, guys, because I'm ready to eat. So, Eve, I've actually been going since this morning. I've had back-to-back calls. By the way, let me tell you guys this. So, I was meeting with our
Same.
tech team tonight, with our head of technology, and this is really exciting. So, in the next 2 days, hopefully this. It may go tomorrow, but it may have to extend to Saturday. So we have now, our test bank has 1,500 questions. So we have now built out 10, the first 10 diagnostic and final exams. So they're for every level. We've got EMT, advanced EMT, paramedic. As of right this moment, what's having to happen is, because we want to get this out to you to help as many people as possible, so that you can kind of gauge, like, are you ready or not? And so these are pretty challenging questions to kind of let you know where you stand or where your weak areas are. So right now, for the next probably few weeks, we'll just have to give you a separate login to a different portal. So you'll log into Class Marker, and that's where you'll take the diagnostic exams or the final exam, the different tests. But very, very soon, our new app, our whole new system will be rolled out. So it'll be like one login for everything. Because right now, like your stuff, some things are in school, some things are in Class Marker and stuff like that. So very, very soon, all of this stuff will be rolled out. It's just we're having to kind of roll it out in phases. It's a huge project. But I just, right before this call, I was actually meeting with the technology team. So that's coming. And just get ready for, in the next couple of days or so, we should have the testing platform ready to go. And what we're having to do is we have to take each one of you and we have to actually give you access to it so that you can unlock yours. And it'll allow us to be able to track your scores to see kind of like what your weak areas are. All right, so that's actually coming. I'm really excited to release that. So Eve, what'd you get out of tonight?
Well, for tonight, for me, was both things. The cardiology aspect of understanding what's behind the ST elevation.
Nice. Okay.
Because I honestly had no idea of what caused it.
Okay,
And
they just tell you
also
that it happens,
the
but not why.
yes.
Okay.
And also all the OB complications. I'm on myself, but I still always confuse the previa and the abruption one.
Okay. So the
So
previa is that going to be painless or painful? All right. So
the
the way you
previa is
remember it,
painless.
okay, and the way you remember this, if something abruptly just tears, that sounds painful. So when it
Yeah.
happens abruptly, that's painful. So the abruption, the abruptio placentae is the painful one, and then placenta previa is going to be the painless one. And that's how I want you to know it. Don't worry about the color of the blood. Just remember painful or painless. Okay, what else do you get out of tonight?
How to differentiate between the stages of pregnancy, like what happens during like each trimester.
Okay.
It helps a lot than to just think like overall pregnancy.
Okay, cool. All right, yeah, and a lot of things are kind of related to timing. Timing is a big issue there. It also, and the reason for that is like if anybody's been pregnant in the group, you know that as the pregnancy continues, hormone levels fluctuate. So initially it starts off where you have like a high estrogen. You have a high estrogen level initially. But as the pregnancy progresses, the estrogen level eventually goes down, and then the hormone that starts to rise that's made by luteinizing hormone is progesterone. Progesterone, if we break that down, that means progestation, in favor of pregnancy. So in order to maintain the pregnancy, the hormone that's responsible for pregnancy, progesterone, those levels have to rise. So estrogen starts off high and goes down. Progesterone starts off low and goes up. So, but all of that happens based on time periods. That's why most of the OB stuff is related to some kind of timing. It's based on timing of hormones. Does that make sense?
Yes, it does. It
Okay.
definitely made a lot more sense to me.
Okay, so how are you feeling about tonight? I know this was a lot. What I do encourage everybody to do is go back and watch the replay. It's not intended for you to necessarily get everything on your first go. Go back and do it. Make sure you can teach it back. Make sure you can draw pictures. Anything else you want to add from tonight?
No, I'm really thankful for that I got to join.
Hey, I'm glad to have you. Glad to have you. All right, so hey, Billy. Let's see, Billy. What you got, my man? Hold on, let's swap him out. It's been a pleasure having you, my man. So how's the experience been? Let me ask you.
Yeah, finally. It was good. Honestly, it helped a lot. I was actually weak with the Cushing's and Addison's disease as well. I
Okay.
think I actually asked you that as well.
Okay. Yeah, I knew somebody asked me. I just didn't remember who.
I did have a question about it. When you were saying the difference between Cushing's syndrome and disease, are they going to have the same symptoms? Like, are they still going to be cushy as you described them?
Yes. So they can have some of the same kinds of symptoms. Well, so actually, I want to clarify that. The one with more of the buffalo hump, the moon face, the cushy, that's actually more Cushing's syndrome. So the difference between a syndrome and a disease primarily just affects one organ. A syndrome is where it starts affecting multiple organs or multiple parts of the body. In the syndrome, that's where you have all those other symptoms because it's multiple body parts. In Cushing's disease, it's primarily just involved in the adrenals. It's where the pituitary gland is causing the adrenals to just make too much cortisol, but it's primarily just in the adrenals itself. So think of most of the symptoms as Cushing's syndrome.
Okay. Yeah, I'm definitely going to watch the replay because I was more or less trying to, like you say in your other videos, watch the story and then take notes later. So that's what I was trying to do tonight.
And the reason for that is because if you're so busy jotting down, you'll miss so much. Especially when I'm moving like my pointer and stuff, like you'll just totally not see that.
Right.
Okay.
It was great. It was very good.
Okay. So how's your the way you were answering questions tonight was great. So before you came into the program, were you able to was your knowledge where it is today?
Oh God, no.
Okay. So
No,
would you
definitely not.
yourself say that your knowledge has improved?
Oh, dramatically. I've only been in part of it since I think June 26th was the day I started, and it's been
Nice.
unbelievable.
Okay, cool. All right, well, make sure you share it with your friends. Tell them, hey, you got to come in with us.
Oh,
Okay.
I already have been. I already
Okay,
have been.
cool. So what did you get? What else did you learn tonight? You learned about Cushing's disease versus syndrome. What else?
The other biggest thing was the difference between the NSTEMI and STEMI. I feel like that's not really taught the best in paramedic school.
Okay.
Just how to see it on an ECG, and then there's no how or why it's actually
Yeah.
happening.
And the
It's just
how is why, because, okay, the how and why. So I always say this to people. Let's leave you in for a second so you can see what I'm doing. Well, I mean, everybody can see this, but I want to see you. There are 5 levels of learning. And so if you've watched some of the videos, you've seen me do this already. There are 5 levels. Okay. Where most people are is at level 1. You know what something is. Okay. I draw a rhythm and I say, what is this? And you say, oh, I know what it is. It's called VFib. And so some people, when that's where their knowledge is, they're like, oh, I know what it is, so I'm good. Level 2 is, what do the protocols say do about it? And they're like, I know what to do for VFib. You defib the VFib. They're in cardiac arrest. The 3 priorities in cardiac arrest are going to be high quality CPR, defibrillation, IV IO access for epi. Well, this is where most people stay their whole career. This is a dangerous place to be. And the reason is if this is all you know, you're going to miss a lot of things, because every patient doesn't present based on what you've been taught in your textbook. There's no one textbook that has all the information, right? And most of you only use 1 or 2 textbooks in your school. Most of you didn't use 1,000 textbooks, right? So there's some stuff that just got left out, because otherwise the book would have to be the Empire State Building kind of size. And ain't nobody got time for that. So the magic happens when you understand the how and the why. Now, some paramedics will incorrectly assume that, Coach, I don't need to know all that stuff. I don't need to understand the how and why. And I'm like, oh, wow, you're a 950. You're a 950 medic. Because 950 medics don't care about the how and why. 3,000 level medics do want to know that. Why? Because sometimes when I have more knowledge, it tells me what to do. Other times it tells me what not to do. Sometimes when I know the how and why behind something, I'm like, the protocol says to do this, but if I do this, I'm actually going to kill this patient. But when you know medicine like this, you're able to call for an order, talk to med control and say, hey, doc, I got this going on. I know the protocol says do this. If I do this, this is likely to be the outcome. Are you sure you want to make me do this? And say it like that on a recorded line. And they're like, no, I don't think we need to do that. Right. But when you don't have the knowledge, you can't come with that kind of confidence. And then, or if you call for an order and say, hey, doc, I want to do this, they're like, nah, just bring them on in. Don't worry about it. I'll see them when you get here. I have never been denied an order ever. Most of my colleagues have been denied lots of orders over the years. I have never been denied an order, because it comes down to just what I know and how I'm able to paint the picture. And when I'm the one standing over the patient and the doctor's in the hospital, I'm like, doc, this is what I got. Are you sure you want me to do this? Now, I've been pulled to the side when I got to the hospital, and they're like, why did you ask for this? But I've always known the explanation. I'm telling you, can you see how your confidence improves when your knowledge goes to another level? Okay.
Oh yeah, absolutely.
Level 4 is where it gets dangerous in the best way. This is where you're able to take something in one concept or context and apply it in a different context. So this is why it's so important that you know the basics and that you know normal. When you know normal for everything, it's so easy to recognize abnormal. The reason most of you struggle is you don't know normal. You're just trying to memorize disease, or what did I read off on page 388 in my book, in the lower left corner that I highlighted 17 times in yellow. Okay. You notice that when I'm up here with you, I don't ever have any notes, but I've just got notes, right? I've just got organized notes, and I got lots of pictures in my head. And then the final level is we want to get to mastery. And none of us may ever get there, but we want to keep getting higher and higher with our knowledge day after day. Today, you should know more than yesterday. Next week, you should know more than this week. Next month, more than this month. Next year, more than this year. Next decade, more than this decade. Your knowledge should constantly be increasing. Billy, the other thing that happens is, let's say you wanted to go to PA school, nurse practitioner school, nursing school, or you want to do something even totally unrelated to medicine. The more you know about anything helps you understand everything else better. Okay? And the more you know and the more you learn, the easier learning becomes. So, like, as your knowledge is going higher now, as we're talking about medicine, think about how much easier it is. Let's say you want to get into business or AI or consulting or anything, project management. Let's say you want to get into something else or you want to pursue a different degree. You're going to be a much better student simply because you're a better paramedic. Does that make sense? Just trust me on this. As someone who's gone to the graduate level, who's a certified flight paramedic, who's gone to medical school, finishing my doctorate to be an emergency physician, I promise you, learning gets easier the more you do it, like everything else. Okay? The reason so many of you struggle is you're just not learning enough. All right? Just trust me on this. I'm going to get off my soapbox. But anything else from tonight? Good session tonight? Cool. All right. Anybody else? Chris and Josue, you got anything you want to add?
I just want to say thank you so much
Who's
for
talking to
the
me?
opportunity. That's me, Chris, sir.
Hey, man. You just started with us today, right?
I did, yeah.
Hey, so how was this session for you today?
It was interesting. I got out, I work at a
he said
hospital
interesting.
in the
Is that
emergency
good or bad?
department. So
Say it
no,
again.
it was great. It was great. Can you hear me?
Okay, say it again.
I'm sorry. I said, can you hear me okay?
Now I can.
Okay. I was just saying thank you. I was at work still when you started, so I missed the cardiology portion of it, like that very first where you were talking about the arteries and ST elevation.
Mhm.
But I caught everything else, and just the thyroid, just understanding thyroid, and it's interesting to see how hyperthyroidism and hypo, they both mimic a lot of other symptoms, I guess, and the treatment, funny enough, is the same
Okay.
almost across the board.
Okay. And notice the
So
pattern that you just recognize. That's why it's not
mhm,
so much that you know all these little details. It's that you're able to recognize what's the problem that's going to kill this patient. Is it an oxygenation problem, a ventilation problem, or a perfusion problem? And
correct.
you're going to hear me say that so much as you go through the cohorts. I'm probably going to say that one line about 100 times because when you know more about the basics, it's a lot easier to figure out everything else. Rather than try to learn 10,000 random facts, know 10 concepts extremely well. I promise you that'll help you way more than trying to memorize 182,000 PowerPoint slides. Okay,
For sure.
I will
Thank you.
outperform anybody knowing 10 concepts more than they know 100,000 random facts. I've been able to pass every one of these EMS exams on my first attempt. EMT intermediate, paramedic, level 2 instructor, level 3 instructor, certified flight paramedic. I passed every exam using the exact strategies that I'm teaching you. I promise you it works. Okay. So I would say, would you say this was a worthy investment of your time and money?
Absolutely.
And this is just your first day, like not even the first whole day.
Yeah, I was trying to, I'll be honest, at first I was trying to figure out, like, am I supposed to be on this? Because like, I don't know where we're at, or I didn't, but I just stuck around, and absolutely, it was very well worth the time and the investment. Like,
Would you
your
say so
pictures,
what's the difference that you notice? And this is your first day, so it's not really fair to ask you that because you haven't been exposed to much yet. But based on what you have been exposed to, literally just hours into your first day, what is the difference that you've noticed?
how you're able to actually draw a picture to explain it.
Mm.
That's interesting.
You keep saying
Again, I
interesting. It
came
makes me
on.
nervous.
No. Like, it's interesting because I thought my learning style, like, the problem was I've been thinking that my biggest challenge or learning style is I have to be in class, like in person, to ask questions. But your pictures kind of answer those questions as we're going along without me even asking them, if that makes any sense.
Oh, wow. Okay.
Like I'm again, I came in right when you were doing the 70%, 30% up at the cardiology
Mhm.
portion of what was it, of
Yeah,
the
we're talking about a
arteries,
non-semi, in-semi.
non-STEMI,
Mhm.
and I've never seen it like that. So I was like, oh, so now I understand what's really happening at the arterial level of things, right? Like,
Okay. Well,
yeah. So I don't know. I guess the pictures just really help a lot, like
okay.
a lot.
Well, if you like pictures, you're in luck because the whole program is pictures.
That's cool. I didn't know that that was a good learning way for me, like a learning
Pictures is
method.
okay, think about it. Since the beginning of time, people have like drawn pictures, carved pictures. When you think about like the Egyptians with hieroglyphics, long before there was written language, people have been drawing pictures. Cavemen drew pictures, right? So it's one of the oldest forms of communication. It's also the universal language. So when you go, like when you're sitting on an airplane, they don't have all these words telling you everything to do. There's a picture of a no smoking. There's a picture of a cigarette with a circle and a red thing through it. You have a stop sign, right? You have a red light. All of these are images, but that's also how the brain works. When you dream, you never dream in like words like closed caption going across your mind, right? that would be weird.
Correct.
But when you
Yeah.
dream, it's pictures and video, it's stuff moving, right? That's
Yeah.
actually how the brain works. It's just that school teaches us to jot down all these notes and bullet points, and then they give us like 182,000 PowerPoint slides. But the brain was never designed to work like that. The brain doesn't work in PowerPoints, the brain works in pictures. That's why I draw pictures.
I love it. Thank you.
You're welcome. And welcome aboard, my man. How long did it take you to make a decision to jump in with us?
I think I initially messaged you on Facebook through one of the groups that I'm a part of, and I'll be honest with you, and I'm not embarrassed to share, is I already took my 5th attempt months ago. I'm on my last attempt.
Okay.
And
you're
it
not by
wasn't
yourself.
yeah, and it wasn't the money for me. It was the like, dang, I've tried everything. I've tried every testing application out there. I've paid the money. You got to imagine, I've paid 5 tests already. And then I kept seeing like, for you, it's not on the Facebook page, at least it's not, oh yeah, like, hey, I got someone else to pass. Great. It was like, here's the evidence, like here's the picture of the individual. Like if you could, I'll tell you right now, if you could put my picture up as a 6th attempt passee, which I believe, hold on, because I even took a note of it. All right. I'm gonna tell you right now. It was God, where is it? You said something, I was like, that's right. That's exactly who I want to be. Was God, and I took a lot of notes, but something along the lines of like, I don't want to just be, I want to pass and be great.
Okay. Yeah.
And so I absolutely do want to do that, right? Like I want to pass and I want to be great, but like, I don't know. I mean, so to answer your question is I messaged you like early June. And then what really sold me was when you sent me those YouTube videos. You're like, hey, look at 5, 6 videos. Tell me if this is a style that works for you. And I was like, when I saw the pictures, I was like, oh, I understand it better. So I think for me, I graduated school and got my cert through school as of last February of 2025. So you can imagine it's been a year long, full of anxiety and just like, dang, I gotta pass. But yeah, so I mean, I'm glad that I found you in that forum or that Facebook page.
Well, we've had plenty of people pass on their 6th attempt, and we have several people who are left to test on their 6th attempt. Just some names that come to mind are just recently, Tiffany, Estevan, Kevin, Jalen, Isaiah, Terrence. I mean, we've had lots of
That's awesome.
Danielle, lots. Danielle's a PHRN, so she's a nurse. that had to take the paramedic. So we've had lots of people just in the last month or two pass on their 6th attempt, in fact. So we've helped many people, and I'm confident that you will do the same. What I recommend for you to do is follow the 21-day game plan. If
Yes,
you have
sir.
any questions, first of all, did you have any, or you hang on for a second. Anybody else have any questions? You stay where you are, Chris, and I'll talk to you. Does anybody else have any questions? We're going to go ahead and end it. Okay. Well, guys, it was a pleasure. By the way, the replay for tonight's session plus the thing of my drawings, that'll go up tomorrow, and it'll go under since we have EMTs in the group, I will put it under the free videos for you. And then for the paramedics, it'll go under the 14 days program at the bottom. So you have cohort 1, cohort 2, cohort 3, and then the live session replays. It'll go under live session replays with today's date. And that'll go up tomorrow. It just takes a while. This video is almost 3 hours long. So it takes a while for that video to render. And so that's what takes so long, but it'll be up by tomorrow. For everybody else, you can go ahead and end. That's it. Thanks for joining with me tonight. I'll see you guys can join the next one Tuesday morning. Check the calendar in school, and it'll tell you what the time is for the next one. But going forward, we should have live sessions on Tuesday mornings and Thursday evenings for at least probably the next several weeks. All right. Good night, everybody.
Thanks, Coach.
Okay,
Appreciate
and
it.
Chris, stay where you are.
Bye, good night,
I'm going
everybody.
to stop the recording, and then
Thanks, Coach.
all right, you guys are certainly welcome. Have a great night.
Recording stopped.